We are live.
A very good evening, everyone, and a very good evening on a Sunday evening. And we are here with us on with all of us on for AIOS GuruSangam 2025-2026 edition, where we educate, excel, and elevate. And this is a session 11, and we'll be talking on UVEA session. And we thank our AIOS dignitaries, Dr. Partha Biswasa, the President, Dr. Santosh Unnava, Sir, Honorary General Secretary, and Dr. Manoj Mathur, Sir, Honorary Treasurer, for drafting this session and making it all available for everyone. We especially thank our speakers, Dr. Ramkumar Satyapal, Sir, from Darbhanga Medical College and Hospital, Darbhanga, Dr. Namita Dave, ma'am, from Narayan Netralaya, Bangalore, Dr. Vijaya Sahu ma'am from AIMS Raipur, and Dr. Nitin Kumar sir from AIMS Jammu, and our expert panelists Dr. Padma Malini ma'am from Narayani Trale Bangalore, Dr. R. Rathinam ma'am from Arvind Eye Hospital Madurai, Dr. Somshila Murthy ma'am from Shantilal Sangvi Eye Hospital Mumbai, and Dr. Sudarshan Sridharan sir from Shankar Netrale Chennai. Thank you very much for gathering together on Sunday evening. And we will be talking about a range of topics, starting all the way from approaching a patient with uveitis, anterior uveitis, how to diagnose and manage, going further to scleritis, and then decoding intermediate uveitis. And we have a perfect panel of speakers for the same. And I thank my co-moderator for joining us, Mahima Kaushal from Center for Sight Hyderabad, and myself, Dr. Rolika Bansal from Mahatma Gandhi Medical College, Jaipur, Rajasthan. So, and without any further ado, I request Dr. Ramkumar Satyapal sir to please share his screen and talk upon the topic of approaching a patient with uveitis. Over to you, sir.
Thank you, ma'am, and thank you, sirs. And very good evening to all our seniors, colleague, and sirs. I'm first time on live Zoom. I'm projecting my some topics that is my of interest of clinical practice, that is uveitis. Can I share my slide now?
Yes, please, sir. And while sir shares his screen, we thank all the postgraduates, undergraduates, and even the ophthalmologists and early stage ophthalmologists, in fact, even the senior ophthalmologists for joining us as audience on a Sunday evening. And thank you for being there. Over to you, sir.
Thank you, ma'am. I'm Dr. R.K. Satyapal from Darbhanga. I was previously posted at NMCH Patna. I did my senior residency at my IJMS Regional Institute of Ophthalmology, Patna. I did my MS from 2004 to 2007 at MSBHU Varanasi under the expert guidance of Dr. Professor M.K. Singh sir, Dr. B.P. Singh sir, and expertise of phaco and squint surgeons. But presently practicing for last 15, 16 years at Patna and now at Darbhanga. I'm a specialist in phaco and squint surgery, but my special interest in the uveitis also. I usually teach my undergraduates and postgraduates in uveitis also. So it was my personal volunteer interest to share some of my experiences and my approach to patient with the uveitis. Sir, second slide, share me. Next, next. No conflict of financial interest. Introduction. Sir, any patient come with the redness or diminish of vision, we classically diagnose at this stage of life that the patient is concerned with the ocular surface disease or conjunctival disease or corneal disease. And the most common that is very much missed by undergraduates or postgraduates, the first year, second year is the circumcorneal congestion, patients coming with redness, mild diminution of vision, and in the hectic OPD schedules, we usually miss the slit lamp examination what we had made, and we are teaching everyone to just pick through the slit lamp examination. We can miss the starting phase of the anterior uveitis. That is the most important part for the management. The patient is having the features of anterior uveitis. Early management is the best management as per my clinical practice, and early presentation, early diagnosis is the most, we can say that rewarding for the patient and boon for the doctors for you can say that saving the vision. So it is very we are very confused right from our study time almost 20 years back. We usually learned the etiological classification, then we learned about the granulomatous, non-granulomatous, so confusion. So finally, that Shan classification come into the light to show us that the anatomical classification is the best for the management and the further progression of the disease and treatment. So we can say that the patient uveitis is usually characterized along several dimensions, that is course, laterality, anatomic location of the inflammation, morphology, presence of active infection, and the age of the host or present of the systemic disease of the patient. Posterior uveitis in that way can be characterized further by whether it is primarily a retinitis, choroiditis, or retinal vasculitis, or whether it is polyfocal, multifocal, or by morphology of the lesion. This characterization narrows the differential diagnosis to one or at the most a few diseases that will just enhance the management protocol for the patient. Then we usually were taught that in the first presentation you should not go for the lab test or lab screening, start with the treatment. But now the you can say clinical practice has changed that we must look for the cause. Although cause is very limited and it is very misleading, but laboratory screening and laboratory testing has come into practice with the advancement of the medical practice. So we can say that laboratory screening should be testing all, that is testing all patients should be reserved for those diseases that can present as any type of uveitis. Whereas targeted testing, that is testing a subject with a specific feature, that is tuberculous uveitis or syphilitic uveitis or anything like that, Fuchs heterochromatic uveitis, used selectively a patient presenting with the other systemic causes sarcoidosis, we target our laboratory screening or testing. Similarly, laboratory testing should be identify an infection. Infectious causes is the most, you can say, missed diagnosis in the cases of early case of uveitis. So infectious causes should be seek out, taken care of, or any systemic disease presenting with only just pain or eye pain and patient is suffering from other systemic disease that is really missed in the regular clinical practice or OPD in the hectic schedules. Uveitis that is not of the established diagnosis is designated as undifferentiated as per the can say our study. We studied in the theories with the course, laterality, and anatomic location. We avoid the term idiopathic nowadays as most identified non-infectious uveitic diseases are idiopathic and most systemic diseases associated with uveitis also are idiopathic. For example, juvenile idiopathic arthritis. This approach should lead to the correct diagnosis of the specific uveitic disease. Uveitis usually now new concept has opened that the most common causes for the uveitis that we are usually seeking for or treating is usually a collection of 30 diseases some article has published, or that is a specific disease, most of the especially that causes intermediate uveitis, or you can say anterior or posterior uveitis. Traditionally, these diseases have been grouped by the primary anatomic location of the inflammation as anterior uveitis, intermediate, posterior, or panuveitis. In the past, a standardized review of symptoms questionnaires often have been used to identify any symptoms of a systemic disease, and a laboratory evaluation conducted to identify the cause of the uveitis. An approach termed etiologic diagnosis of the uveitis, we already acquainted with that. What I was asking that currently we follow that 30 diseases are mostly you can say causing the disease or recurrent presence or unilateral or bilateral that is associated with some other systemic causes. We can say according to the anatomical location, infectious causes the most common are the CMV, anterior uveitis. These are all the collection of 30 diseases. We can see that herpes simplex, anterior uveitis, varicella zoster, anterior uveitis, syphilis, and some diseases are intermediate, that is causative are syphilis and Lyme disease, very notorious. Posterior uveitis, we all see in one or two cases, or you can say 3 monthly, we usually see the scar of toxoplasmic retinitis, CMV retinitis, very common in the clinical practice of our medical colleges. Acute retinal necrosis, very rare cause. Progressive autoretinopathy, it's also a rare cause. But you can say we can see that the infective causes are the most common for all the 3 anatomic locations. And then the systemic association that why we should go for the HLV27 associated anterior uveitis, juvenile idiopathic arthritis associated with uveitis, Behçet's disease, sarcoidosis. These are all the causes, intermediates, most common causes that is multiple, sarcoidosis and multiple sclerosis associated uveitis. In pars planitis, we usually found it is truly idiopathic, that is no cause is seen. Intermediate uveitis, other class we say that intermediate uveitis with the cause, we get the cause, that is called intermediate uveitis. We don't get the cause, we define it as pars planitis. Similarly, posterior uveitis causes are very much clear from nowadays, and rare causes, that is geographical distribution, not seen everywhere, that is serpiginous choroiditis or acute posterior multifocal placoid pigment epithelopathy, even SN white dot syndrome, bloodshot chorioretinopathy. These are certain diseases, and one we get that is sympathetic ophthalmitis. Trauma cases is very notorious nowadays. We usually deal a large number of cases of that should be also screened. Although the risk of sympathetic ophthalmitis is very rare, but the second eye is always look for in the traumatic cases. So our approach should in the uveitis should be the concern of the systemic causes of the complaint with the patient come with. That should we have a comprehensive mind that we should look for, what we should look for, and what initial management. That is the clinical, very clinical. I don't think that the approach to the patient with uveitis is laboratory dependent. It is clinical dependent. In my sense of clinical sense. Nomenclature was defined as that naming missing approach by Smith and Nozick. Then no underlying cause of on a specific syndromic name cannot be given. These are the stories of the past. That was idiopathic uveitis. Now we can coming to the sun classification. Etiologic is something else. We have to look for the cause. That is something else must be their manifestations. Etiology is the most complex disorder that is unknown. In fact, etiology of the most complex disorder of the uveitis is unknown. Risk factor can be identified and pathogenesis inferred, but except for the infectious diseases, we see that the Mendelian genetic disorders and drug or foreign substance related identification of the etiology. Hence, etiology diagnosis of the uveitis is a misleading concept. The best what we read today, otherwise is a specific, I already shared such specific uveitic diseases. Goal of the diagnosis should be specific according to the systemic cause. Characterization of the uveitis, that should be carefully characterizing several dimensions. That is the history that starts with history examination and the selected disease imaging. The most we follow the nomenclature, that is the standardization of the uveitis nomenclature project. That is also a criteria used for research reporting for the major uveitic diseases, and now adapted at the clinical care, that we say that the patient is suffering from anterior or intermediate or posterior or pars planitis. We treatment differs with different anatomical location. We all know that the treatment is very, very different with different aspect of the anatomical location of the disease. Course of the disease is also another how the course of the disease occurs. Is it onset is sudden or insidious? Duration is limited or persistent? We can say that the sudden onset disease of limited duration is considered acute disease, whereas chronic disease typically is insidious in onset. Always patient, we most common see the chronic diseases. This is having presently complaint with posterior shanikia, or you can say iridocapsular adhesion, patient coming with the mild cells and flare. And a patient complains that I was having headache, taken local drops, and they come with a repeated, you can say that the finding suggests that the patient was having recurrent assault of anterior uveitis, but presentation is very less with a persistent duration. Acute phase may be monophasic with a single limited in duration episode for research purposes defined as less than 3 months, or recurrent. The key of recurrent acute disease is the presence of episodes of active inflammation separated by a period of no inflammation, but not on therapy. That is the recurrent is when there is you can say no inflammation, that is no signs of cells or flare like that. Conversely, chronic disease relapses promptly. The definition here is we have to define that the course insidious onset, sudden onset, is it acute phase or recurrent, or it is chronic disease. Now the classification has come into the acute and chronic disease. Acute disease or chronic disease. Acute में Acute by sudden onset, right? We can say that the recurrent episode. If these terms are used precisely, the often seen term chronic or recurrent uveitis has no meaning. Furthermore, precise characterization will guide therapy. Recurrent acute disease may need only treatment of acute attacks, whereas chronic disease is likely to need chronic suppressive therapy. That is the sole classification. Clinically, we have to uh, say the patient that the patient is having a recurrent acute disease or chronic disease. That is, I learned that these are the things that should be very much well explained to the patient, that he should come repeatedly if he is having a chronic disease, that he should not stop the drugs without the advice of the physician or ophthalmologist. Then we come to the unilaterality or bilaterality. Laterality is second dimension of the diagnosing, or you can go for the classification of the uveitis, that may be unilateral alternating or bilateral simultaneous or bilateral asynchronous. Unilateral alternating disease either may be affected by an attack, but only one eye is affected at a time, and the attacks are episodic and recurrent in nature. That is, unilateral alternating disease is defined as one eye is affected at a time, and the attacks are episodic and recurrent in nature. Conversely, in bilateral asynchronous disease, the onset in the two eyes is not simultaneous, but both eyes remain affected after involvement begins in the second eye, and the disease typically is chronic in nature. Third dimension is the best, I think, anatomical dimension, you can say. That is already I have covered anterior, intermediate, and posterior, and panuveitis. The anatomic class of uveitis is based on the primary location of the inflammatory reaction, not on the location of any structural complication. For example, macular edema. So this is the core, you can say, essence of the classification, that it is depends on the location of the inflammatory reaction. Like anterior uveitis cells are seen primarily in the anterior chamber. There may be some retrolenticular cells present, that is iridocyclitis, but inflammation does not extend all the way posterior through the vitreous. Inflammation primarily in the vitreous is termed intermediate uveitis. There may be a mild anterior chamber reaction, where should not be anterior segment structural complications such as synecdoche or peripheral anterior synecdoche. If there is substantial anterior chamber reaction with a structural complication, the uveitis should be classified both anterior and intermediate uveitis. That is the markable point, and the treatment is done according to the this condition. In posterior uveitis, there are chorioretinal inflammatory lesions. In some diseases, there is an accompanying vitreous inflammatory reactions. But in panuveitis, inflammation affects the anterior chamber, vitreous, retina, choroid, but no one location predominates. As with classification system, there is some arbitrariness in the classification and apparent inconsistency based on historical naming of the syndrome. Hence, multifocal choroiditis with panuveitis is considered a posterior uveitis because the primary inflammation is in the choroid, and the accompanying anterior chamber of vitreous section typically is mild. Posterior involvement can be further subdivided based on the primary site of inflammation. Posterior can be further subdivided based on primary site of retinitis, choroiditis, and retinal vasculitis. Although there is some variability in the use of the term, in this context, retinal vasculitis should involve inflammation of the retinal vessels, preferably with evidence of vascular occlusion. Mere leakage should not suffice. Macular edema is not retinal vasculitis, even though there is vascular leakage. Retinitis and choroiditis can be further described as paucifocal, effuse spots, or multifocal. Sometimes the term focal is used interchangeably with paucifocal and interpreted as distinct from the multifocal. In immunologically normal host, retinitis typically is paucifocal. That is a markable point, sir. Immunologically normal hosts have typically paucifocal and is nearly always infectious in nature. That is a markable thing that is we all have discussed. We see the cases more commonly, toxoplasmic retinitis or acute retinal necrosis. Multifocal retinitis does occur, but it occurs in immune-compromised host and is infectious in nature. Choroiditis may be, another one is, sir, choroiditis that may be paucifocal or multifocal and may be either infectious or immune-mediated in nature. Although presumed immune-mediated multifocal choroidopathies occur in immunologically normal hosts, for example, bloodshot choroiditis, infectious multifocal choroiditis typically are seen in immune-compromised hosts. The choroidal lesion of the multifocal choroiditis can be further described by the short phrase that leads to a likely diagnosis. For example, the lesions of the serpiginous choroiditis are amoeboid or serpentine. Some of the those of acute posterior multifocal plywoid pigment epithelopathy, plaque white. Those of bursar chorioretinopathy, yellow range of white. Those of multifocal choroiditis with pannivitis, punched out atrophy. So according to the lesion, we also we can name the uveitis, especially the posterior segment uveitis, that is posterior uveitis. Those of punctate inner choroiditis punctate, and those of multiple evanescent dot syndrome. This is the normal things and inflammation, that is in 2005 nomenclature was designed, and that was used for the research purposes and for the clinical uses. These are the definitions we all know. Just shifting to the next slides. Intermediate uveitis inflammation that will be dealt with the other sir. Now I'm coming to the what was the classification that was the base for us on learning and teaching for the PG students and postgraduates. That is the locations that is definitely classified, and that should be remembered by everyone. That is anterior chamber reactions, prime sort of inflammation, iritis, iridocyclitis, anterior cyclitis. Intermediate uveitis, that is primary site of inflammation is vitreous. That includes pars planatis, posterior cyclitis, and hyalitis. And third one is the posterior uveitis, that primary site of inflammation is retina or choroid. That may be focal, multifocal, or diffuse choroiditis. Choroidetinitis, retinochoroiditis. Both are interchangeable. What is the first site of lesion? Accordingly named like that. Retinitis, pure inflammation or lesion at the retinal layers. Neuroretinitis involving the octave layer also. Pannivitis, all the layers, anterior chamber, you can say vitreous and the retina. This is the base for our classification or the course of the disease and the management protocol. We follow this from the nowadays. And other descriptors of the uveitis based on sun criteria was the according to the onset. That is, onset is sudden or insidious. Duration is limited, less than 3-month duration. Course persistent, 3-month duration. Course acute, recurrent, or chronic. That is typically defined, sir. Episode characterized by sudden onset and limited duration. Recurrent is repeated episodes separated by periods of inactivity without treatment greater than or equal to 3 months in duration. Chronic is persistent with uveitis with relapse in less than 3 months after discontinuing treatment. Uveitis terminal based on criteria is inactive. We also classify clinically inactive stage, worsening activity, improved activity, remission in the follow-up cases. We define as grade cells according to the number of cells in the typical slit lamp morphological beam of light. We say grade 0 cells in the 2-step increase in level of lamination, that is anterior chamber cells, vitreous, or increase from grade 3 plus to 4 plus. Improved activity, 2-step decrease in level of inflammation, like that. Remission, inactive disease. What is we define remission according to sun criteria as inactive disease for greater than 3 months after discontinuing all treatment for eye diseases. That is most important while dealing with the complicated cataract and starting that looking for the emulsification or cataract surgery for the disabled patients suffering from the uveitis. Gross analogy, we can say I have made a etiological classification that idiopathic. We say that 25 to 30% exogenous, also endogenous for the knowledge point of view. Secondary to systemic, basically that is syphilis, TB, and leprosis, sarcoidosis, ulcerative colitis. All are associated. Classical associations are found. We have seen the cases of ulcerative colitis presenting with the arterial uveitis, sarcoidosis. Secondary to infection, very common viral, fungal, parasitic. Day-to-day practice, we see that lens-induced uveitis, idiopathic specific uveitis like pars planatis, Fuchs, trachonic cyclitis, sympathetic ophthalmitis. Others are muscular syndromes. Septic infection also lead to uveitis. Direct spread from cornea, sclera, retina, very common. Specific HLA associated is HLA3 are already, we say that we have read from the last many years that HLA-B27 is associated with acute anterior uveitis, HLA-B5 is associated with Behçet's disease, and HLA-DR5, that is with Vogt-Koyanagi-Harada syndromes. Another classification, many classifications are there, but causes, most common causes for the anterior, that usually non-granulomatous and granulomatous according to the, you can say, formation granulomatous, granuloma formation on the iris, that is HLB-227 associated traumatic Fuchs UGH syndrome, Kushner's Sloan JR, juvenile rheumatoid arthritis, irritable bowel disease, and drug-induced or non-granulomatous anterior uveitis. Causes of granulomatous are sarcoid, TB, syphilis, herpes. We say that I already told that 30 diseases are the most notorious for all the segments of all the classification of the uveitis. All the we are saying that sarcoid, TB, syphilis, all are notorious for the uveitis. Systemic infective diseases, herpes simplex, leptospirosis, brucellosis. Uh, in the most common cause of intermediate uveitis are idiopathic, that is also known as Bart's splenitis. Other causes are multiple sclerosis, tuberculosis, syphilis, Lyme disease, and sarcoidosis. Posterior, we defined as vitritis, retinitis, and choroiditis. Vitritis, we again idiopathic, that is senile vitritis. Toxoplasmosis, most notorious for the in the posterior segment, toxoplasma disease, endophthalmitis, now rare days in the practice, but we do get lymphoma, in the Hodgkin's lymphoma, that metastasis that lead to the uveitis. Retinitis is the focal and multifocal. Focal is typical classification for toxoplasmosis, multifocal for the syphilis. CMV retinitis also causes focal retinitis, and multifocal we have got a glossary of diseases, other like very rare one, acute retinal necrosis, posterior outer retinal necrosis, McEwald, MEDW syndrome, deviation, and Ills disease, choroiditis, focal and multifocal. That is again, that is focal tuberculosis and toxocara. Multifocal, we have a glossary, and other one that serpiginous choroidopathy, birdshot lymphoma, acute placoid multiple pigment epithelopathy. Panuveitis, most common cause is sympathetic ophthalmia, VKH syndrome, Behcet syndrome, endophthalmitis, sarcoidosis, paragonophylaxis, Lyme disease, and vascular syndrome. Uh, we learned grading. Importance of the grading is that we start our treatment according to the grading of the cells or flare, mode of treatment, frequency of putting the eye drops, where we should use the systemic steroids, where we have to shift for the immunomodulators. We manage according to all our follow-up depends upon the slit lamp examination, that is the core and you can say the heart of our diagnosis and the future prognosis and the management protocol. That definitely demands slit lamp examination, that we should look after in each and every visit of the patients. For the anterior chamber cells, flare, grading must be documented, vitreous cells or opacity. And these are the classical definitions: wide beam and narrow slit. Then we must have some concept of HLB-27 associated systemic diseases that are very notorious for causing uveitis. As we know, as we see that the complications of uveitis is very lethal and threatening. Or as per my clinical experience, early management and aggressive management and intelligent management is the core for salvaging the vision of any suffering patients from the uveitis, as the uveitis itself is very, you can say, notorious and very unrelentless progression of the, since this is highly diagnosed or highly pathologically is the immune modulated. Every host has a different immunity. Every host react to every antigen, let it be infective, non-infective, or anything like that, with different, you can say, different strategy. That a strategy will either win or lose. If he loses the sight. If he win, is fair. We are only the supporters for just giving the steroids or like pain relievers. We are not doing much more except that immunosuppressions, anything like that. So early management, diagnosing, and you can say explaining the patients is the most important. Last part is the how to approach them. We already teach that we should approach the patient. We should teach them. We should make them cognizance of their disease, their progression, their management, Although laboratory tests or other tests are that is supportive, but that is not the treatment that it for certain diseases that is very important. But many cases we get idiopathic, or you can say we do not find any cause. Seronegative arthritis, many patients come in with the joint pain, young patients, they are suffering from the secondary cataract, or you can say complicated cataract. So we should look for Ritter syndrome, ankylosing spondylitis, psoriatic arthritis, and inflammatory bowel disease should be screened for the anterior uveitis changes or anything like that. Other diseases that are seronegative spondylar arthropathies are that is negative RF factor. We look for the rheumatoid factor, cyclic citrullinated peptides. Seronegative are family of joint disorders that classically include ankylosing spondylitis, psoriatic arthritis, inflammatory bowel disease, reactive arthritis, and depressed central psoriatic arthritis. These are uh, these are the common causes of acute and chronic anterior uveitis, and that is HLA-B27 anterior uveitis, most common ocular involvement only, ankylosing spondylitis, reactive arthritis, psoriatic arthritis, inflammatory bowel disease. These are the differential diagnosis for the acute and chronic. We must look for the cause, and I think that during the process of treating any uveitis, we keep on searching for the cause. This is a case of hypopyon anterior uveitis with hypopyon. We have got two HLA classes, HLA class 1 and class 2 subclass, and antigen T cell presentation. These all are certain things for the we can say that these are the factors that HLA-BC, ABC classical, most common somatic cells presentation is there. Antigen presenting dendritic cells, HLA class 2. These are the we can say that the for the immunity related diseases. Simplified scheme for patient evaluation uveitis is a very glossary, large scale. We can say that acute sudden onset, what we should possible associated factors, suspected disease, and the laboratory test, what we should ask or seek for, or what we recommend. When the patient is acute, presentation is acute, sudden onset, severe without fibrin membrane or hypopyon, we must possible associated factors look for, that is arthritis, back pain, GI symptoms, oral and genital ulcers, febrile illness, flank or abdominal pain. These are things we usually miss in our clinical practice. We don't have so much time to linger our time, or say give time to the patient, but that should be our teaching in the teaching protocol, that should be make mandatory for the cows. Then a suspected disease are like in anterior uveitis acute cases, seronegative spondyloarthritis, Behçet's disease, that is orogenitis, we suspect for Behçet's disease, tuberculous nephritis or uveitis syndromes, infectious endophthalmitis, toxic anterior segment syndrome. Laboratory testing we will deal in the later slides. What is important, what is not important, is that mandatory or not. But HLB27, we go for the HLB27 titer or screening. Sacroiliac films, that is X-ray film, is very easy. Rheumatology consultation, gastroenterology referrals, we can do it in our clinical practice also. For moderate severity, shortness of breath, that is sarcoidosis, that suggests of lung disease. Mild to moderate presentation, if the patient is having shortness of breath, skin finding, granulomatous inflammations, peak exposure. These are certain suggestive things that will tell about the systemic causes, as is sarcoidosis, or exposure to tick disease. Lyme disease can also be anterior or posterior panuveitis. Over age 50 years, we also suspect for the intraocular lymphoma. Age factor is also a factor. After 50, if the patient is having recurrent mild to moderate uveitis, we should also look for the intraocular lymphoma. Workup should be done. Chorioretinitis with vitritis, these are the OCT. Now we image the retinal pictures by optical coherence tomography, or easily we can say dilated fundus, direct ophthalmoscopy we see, and we classically, this is the spot diagnosis for many cases of the posterior uveitis. The lesion is focal, multifocal, duration of the disease, vision magnitude of the vision loss, other associated feature, past medical history, past systemic medical history. These are all other things that will definitely lead to the diagnosis and the mode of treatment, and our prognosis of the patient will be good. Granulomatous and non-granulomatous uveitis. Classical changes onset is in non-granulomatous acute, pain is very marked, photophobia is marked, blood vision moderate, circumcorneal flush is very marked, kinetic precipitate is fine white, pupil small and irregular, posterior synechia sometimes, iris nodules none, sight is anterior, course is acute, recurrence is uh, in granulomatous, it is insidious, very classical. Insidious, painless, less pain, anterior uveitis. We look for the granulomatous. You can say uveitis causes. Blood vision is very marked. Circumcorneal slight kinetic precipitate, large gray mutton fat capes is the typical teaching for the undergraduates also, and for us. These are the classified according to granulomatous, non-granulomatous. Symptoms and signs of acute anterior uveitis. Very classical sign and symptoms. Chemical mediators involved in the inflammation result in vascular dilation. Increased vascular permeability leads to aqueous flare, chemotaxis of inflammatory cells into the eye, aqueous and vitreous cellular reactions. That was slit lamp major finding it is presence of inflammatory cells and flare in the anterior chamber, but there may be additional sequelae. The sun system grades the intensity of anterior chamber cells according to the number of inflammatory cells observed on slit lamp examination in a field defined as 1 millimeter high power beam of full intensity at 45 to 60-degree angle in a dark room. Flare is defined by the visibility of the slit beam in the anterior chamber. The sun system adopted the flare grading method described previously by Hogan and colleagues. This is the classical classification: less than 1, 1 to 5, 6 to 15, 16 to 25, 26 to 15, greater than 15. That is fibrinous or plasmoid aqueous. Anterior chamber reaction, serious, purulent. Classification is other one, fibrinous or sanguine. KPs is the classical finding seen in the acute anterior uveitis, collection of inflammatory cell on the corneal endothelium. Newly formed KPs tend to be white and smoothly rounded, later transitioning to the crenated, shrunken, pigmented, and glassy in nature. Large yellowish KPs are called mutton fat KPs and are usually associated with granulomatous type of inflammation. Associated corneal edema may be present. Band keratopathy is a typical sign of chronic uveitis, especially in juvenile idiopathic arthritis associated. Iris involvement may manifest as either anterior or posterior synecdoche. Iris nodules, that is Coppage nodule as the pupillary border, Basaka nodules within the iris stroma, and Burles nodules in the angle. Iris granulomas, heterochromia, that is classical features of the Fuchs uveitic syndrome, or stromal atrophy, that is herpetic, typical finding. These are certain pictures of the slit lamp beam. Aqueous flare are seen, cells, and that is endothelia, that is KPs. We see classically like this in many cases of acute anterior uveitis. These are the mutton fat KPs, ground glass appearance, Basaka nodules in sarcoidosis, Coppage nodules present at the pupillary margins, sir. Fibrinous membrane in the anterior chamber between cornea and iris. These are the looks we see that the typical finding of acute anterior uveitis. These features we do not find in the cases of intermediate or posterior uveitis. Classical picture of most common presenters in our clinical practice of the cases of acute anterior uveitis. Pupillary membrane with hypopyon, we can see that there is occlusio pupilli and there is hypopyon, marked congestion, ciliary congestion, that is that condition leading to the secondary glaucoma. Gonioscopic showing fibular deposits in the angles. These are certain things that should be clinically detected or that should be followed up in the treatment of the severe cases of acute anterior uveitis. Multiple posterior synechia preventing complete dilatation of the pupil. These are the sequelae of the you can say acute anterior uveitis secondary complications. details. How should we go for the treatment after learning the classification causes? Although 30 causes I have enumerated, that is the most common. Four-pronged approach is now advised, that is detailed history, ocular examination, physical examination as and when required, and ancillary investigation as and when required. These are the four basic things that should be done. Ocular investigation, we have the support of BS scan ultrasonography if the aqueous is very turbid or the fibrous clear is there. We can look for the posterior segment part. Vitreous is there in vitreous age or vitreous, you can say turbidity, anything like that, or fluorescent angiography. Optical, that fluorescent angiography will classify the choroiditis, retinitis, and the other causes of many things. Optical coherence tomography for assessment of posterior segment is now the gold standard for day-to-day practice. Ultrasound biomicroscopy would be used in case with a small pupil hypotony to assess the ciliary body and the presence of cyclitic membrane. Laboratory rank order test of possible diagnosis should be made from the history and examination. I already said that the history, clinical examination, the presentation is the usually diagnosis that gives us 90%, and the most common causes are usually elicited in the can say clinic or our OPD. And an investigation should be tailored to confirm the diagnosis. Investigation
Very
of
sorry for the interruption, sir. But
sir.
may I request you to summarize due to time constraints so we may stay on the schedule, sir?
Okay, ma'am. May I get 2 minutes more, ma'am?
No issues, sir. Yeah.
Okay, ma'am.
Just
Just
a
I'm
second.
sorry, I want to finish, ma'am.
All right. Yes, please go ahead, sir.
The basic things, ma'am, investigation of a patient with first episode of the anterior virus will depend mainly on the history and examination. That is not mandatory. Investigations are not required in the first episode of non-calanomatous anterior uveitis or in herpes zoster ophthalmic uveitis and Fuchs heterochromic iridocyclitis. These are the certain glossary of what we should ask the patients for the lab test or X-ray studies, or whose patient should be referred. There is a glossary, certain named diseases, that is ankylosing spondylitis, inflammatory bowel disease, Ritter syndrome, psoriatic arthritis. These are the very notorious for. So you can say that intermediate or posterior uveitis, an acute anterior uveitis, juvenile rheumatoid arthritis, sarcoid arthritis, and tuberculosis. Lab tests routinely we learned from the last 20 years that complete blood count, ESR, Montex, BDRL, treponemal pallidum, hemoglobin test, HLA-B27. HLA-B27, where we do that. Patients are so poor coming in the day-to-day practice. But this is important if the side-saving conditions is there. Although the history generally lead to the diagnosis, there is no need for laboratory testing. Another special, I just want to seek 30 seconds more, ma'am. Sarcoidosis deserves a special mention. It accounts for 5 to 10% of all cases of itis in large surveys. I think this is out of the scope of my topic, but I think sarcoidosis is a special case that is affected. Lungs are affected, skins are affected, reticuloendothelial systems, liver, spleen, lymph nodes. This is that is a common finding we look for, and screening with ACE, angiotensin converting, is not warranted. But this is a very sensitivity and specificity is there. Gallium scans 91% respectively. HLA tapping has limited diagnostic usefulness, as we all learned. HLA tapping should go for, is that important or not? That is very dubious thing, and very I don't know that it is very useful, and that screening all patients with a given diagnostic classification for HLA typing typically is a very low positive predictive. That all I was to say. Usually less than 20%. So why to go for only look for the HLA typing? And routine screening with HLA typing has limited usefulness. Conclusion: in this perspective, we have addressed how to approach a patient with what is to identify correctly the specific disease. I was just treatment should be started without any other process, because early treatment is the best treatment, as I clinically learned. And discussions at table are not exhaustive but illustrative. Now we have concluded, or we have concentrated on the 30 more separate diseases that should be looked for. We should stick to our management according to the SUN project or SUN classification. The approach to the diagnosis of a system is pragmatic. It is based on the concept that if there is no evident end-organ disease, or there are no implications of therapy or the patient systemic health, then there is no reason to pursue exhaustive laboratory searches with trace or limited positive predictive value. Thank you, ma'am. I think that concludes me. Thank you for patience hearing and giving me opportunity. Thanks, AIS and sir, respected Dr. Padma Malini, ma'am, Dr. Ratnan sir, Sumay Silamurthy sir, madam, Sudarshan sir, and my esteemed speakers today. Thank you all for patience hearing. Over to you, ma'am.
Thank you, Dr. Ramkumar Satyapal sir, for that very clear and insightful presentation, especially how you've summarized anterior, intermediate, posterior, and pan-uveitis, along with their syndromic presentations and approach to each and every one of them, which can frankly be difficult and challenging for the early career ophthalmologists and postgraduates. I'm sure they all will benefit if they're logged on. And I'd now like to open the floor for discussion from our expert panel to please enrich the session with their insights and their experience.
Thank you, Dr. Ramkumar,
Thank you, ma'am.
for the elaborative lecture approach to uveitis. Yes, as Sir pointed out, it's important that we need to have a thorough history taking and complete ocular examination, which includes dilated fundus examination with scleral indentation. Only when we do that, we could make out the anatomical diagnosis, and then thorough systemic evaluation. For example, if the patient walks into a chamber, we have to observe them. If they have any joint deformities, or if they have herpes zoster scar or malar rash or skin rashes, all this can pinpoint what could be the systemic disease can be associated with it. And then once we make the diagnosis, what is anatomical diagnosis and what is probable cause, we do a naming and meshing. Based on the naming and meshing, we will put the differential diagnosis. Once we make the differential, and then we order the tailor-make investigations. We don't order all the investigations. We have to selectively put the DD accordingly. We have to order once we get it, and we have to manage these patients. As Sir pointed out, it is most often is multidisciplinary approach. If the patient have associated systemic disease like ankylosing spondylitis or JAA, we can't manage alone with topical steroids and cycloplegic. We have to refer to the concerned specialist, for example, dermatologist or a physician, to start the systemic therapy as well.
Thank you, ma'am.
Dr. Sudarshan sir, would you like to add your remarks?
Yeah, nice talk, Dr. Ramkumar. I'm heard,
Thank
right?
you. Thank you, sir.
Yes.
Yeah. So, like you said, it's very important that it's no longer true that we can skip lab test if it is the first attack, unless you have a specific cause, like a drug-induced or a trauma one. So it's better to test as per the phenotype. So Sun Working Group, few points are that Sun Working Group 1 was more like a research type. Sun Working Group 2 actually has a very, very good reason that you need to follow it, because it gives you what investigations you need to do, and probably helps you clinically also. So
Yes.
most of the time, no, the test has to be like, if you're allowed to do one investigation, which will you do for each of the presentation? That's how you try to do the test. It's not that you do the whole uveitis workup for everything. I mean, like that should be your first DD. So it's like you said about whether it's granulomatosis, non-granulomatosis. History, of course, is important. Like I keep telling that pattern recognition is very important. Like uveitis is something like dermatology, where you see in dermat you actually see the findings, and then you ask for history, ask for the test. Sometimes uveitis is also like that. Like you first see the findings, and then also you can ask for the test. Not necessarily that you go through the whole thing as a whole. Basically, uveitis is about history examination, but the main concept is that you try to treat the inflammation and reduce the recurrences. So in infective causes, you treat the inflammation by steroids, and reduce the recurrences by treating the cause. Cause is the specific anti-infective agent. In non-infective conditions, you treat the inflammation by steroids and reduce the recurrences by immunomodulators or biologicals. So that's the basic concept.
Yes.
Whatever you do, ultimately you come down to that. Another important thing you should remember is that you need to know which are important and which need to be addressed early, which are vision threatening ones. So few things you can you said about acute, chronic, which can be recurrent and all that. So sometimes you need to use IV methylprednisolone. Sometimes you need to use intravit. So you need that also you need to figure
Yes,
out
sir.
be in the beginning itself whether you need to be more aggressive or not. So that's more important for you to approach the uveitis.
And
Thank
also,
you,
like
sir.
Dr. Sudarshan said, it's like, important where we have to sight-threatening lesions like endophthalmitis or acute retinal necrosis or necrotizing herpetic retinitis, where we have to recognize and start the patient at the earliest instead of waiting for the lab reports. An appropriate referral is also mandatory.
Okay, ma'am. Very well, sir. Thank you, ma'am.
Thank you, Dr. Padmalini ma'am and Dr. Sudarshan sir, for your valuable insights. I'd now like to welcome our next speaker, Dr. Namita Dave, for her talk on anterior uveitis, diagnosis and management. Over to you, ma'am.
Yeah, am I heard?
Yes,
Yes,
ma'am,
ma'am.
you're audible.
Yeah, I'll just share my slide.
Please, ma'am.
Is my slide seen here? Are my slides visible?
Yeah, visible.
And I'm heard? Yeah. So, good evening, one and all. We're talking about uveitis. Very often, you have patients coming in with a red eye in the IOPD, and you are struck with a number of diagnoses, which can range from subconjunctival hemorrhage to conjunctivitis and emergencies like acute congestive glaucomas and uveitis. I shall restrict myself to identifying the red eye caused by uveitis, and in particular, anterior uveitis. Now, the standardized uveitis nomenclature group classified anatomically the uveitis into anterior uveitis, intermediate, posterior, and panuveitis. And we have had other classifications like etiological classification, where the etiology led the diagnosis. Classification other than that was pathological classification, which based on the presence or absence of granulomas on the endothelium of the cornea. And other classification methods included were diagnosed by the course and laterality of the uveitis. However, this was in 2005. Later in 2021, the Sun classification 2 was introduced, where they use the machine learning based approach, where they use the primary methods of classification like anatomical location, etiology, and descriptors of the descriptors like onset and laterality to diagnose the disease. Now, for example, here we had a patient with anterior uveitis as the anatomical class, and there was an association with spondyloarthropathy, and the course was recurrent and acute. So this leads the specialists to look for signs like a unilateral, acute, and a painful presentation with high likelihood of recurrence, pointing to the diagnosis of an HLA-B27 associated anterior uveitis. It further describes the anterior uveitis as anatomical class as anterior, infectious causes, systemically the systemic disease associated, and eye limited as in case of Fuchs uveitis syndrome. This making a diagnosis of uveitis and categorizing them much easier. Now let's go back to the basics of anterior uveitis, which affects mainly the iris and the ciliary body. And the patient comes to the OPD with symptoms like pain, which may be dull, aching, or throbbing, and maybe affecting referred to the forehead or the scalp. There will be redness, which is typically circumciliary as a result of the hyperemia of the anterior ciliary vessels. There will be lacrimation that occurs due to the lacrimatory reflex, photophobia due to reflex between the sensory fibers of the fifth and the seventh nerve, which is the efferent. And there's defective vision, which may be vary from mild blur to a marked deterioration which can be as a result of either a ciliary myopia due to a ciliary spasm, or there may be corneal edema because of corneal haze due to corneal edema or keratic precipitates. The aqueous may be turbid, or there may be presence of a pupillary block due to exudate, or a complicated cataract, or some amount of vitreous haze may be present. What are the signs that we are supposed to look for in the case of anterior uveitis? Edema, lid edema may be very mild, but there is marked circumciliary congestion. Look for the corneal signs, which may be a presence of corneal edema, which may be a result of toxic endothelitis or a raised intraocular pressure. Presence of keratic precipitates, which may be various types, which I'll explain a little later, these are cellular aggregates on the endothelium of the cornea, mostly in the lower part, which is described as the arch triangle, or they may be diffusely present, or in chronic cases, there may be a posterior corneal opacity. Next is the anterior chamber signs. What are they? They are cells, aqueous cells, and flare. Now, how do we look for them? We take with an oblique beam of the slit lamp with a dimension of 1 millimeter to 1 millimeter with maximum magnification and illumination. We learn to identify the cells and grade them according to the sun classification. Then we have the cells, the flare, which are basically protein exudates in the anterior chamber, which sort of are seen as suspended particles because of their Brownian motion and the phenomena due to the Tyndall effect. Then we have the hypopion may be present, which may be dense due to and slow absorbing because of the high fibrin content. This is typically seen in HLA B27 cases. Or there may be a mobile hypopion which quickly absorbs because of the low fibrin content, classically seen in Behçet's disease and sometimes in herpetic anterior uveitis. The hypopion may be hemorrhagic, which is often seen with herpetic anterior uveitis, traumatic uveitis, and if there is a presence of rubeosis iridis. There may be a change in the depth of and shape of the anterior chamber. This is basically guided by the presence of segmental posterior synechiae. And sometimes when the synechiae is almost total or annular, you can also get a sort of a funnel-shaped anterior chamber. The changes in the angle of the anterior chamber can be seen by doing a gonioscopy, wherein you can see in the acute cases, there'll be fibrillar deposits. Sometimes you can have granulomas. And in chronic cases, peripheral anterior synechiae. Now, the iris changes that we see, there will be a loss of normal pattern of the iris due to inflammatory changes in the color, iris color due to the pigmentary loss. There may be presence of nodules in the iris. Now here there may be either Coppé's nodules, which are along the pupillary margin. These are basically ectodermal granulomas and can be seen both in granulomatous and non-granulomatous anterior uveitis. Well, the Busaka nodules are seen along the collarette in the iris stroma, and these are diagnostic of granulomatous anterior uveitis and are basically mesodermal floccules. The pupillary signs that we need to look for are narrow pupils. Why are they narrow? Basically because they are, the sphincter pupillae are irritated because of the toxins released, and there may be edema of the iris tissue. The pupilla may be irregular. Maybe that is because of the presence of posterior synechiae. The ectropion UV may be present, where the pupillary margin basically everts due to contraction of the fibrinous exudates on the surface of the iris. The pupillary reaction, where the pupil is mostly sluggish, or sometimes it may be absent due to the edema and hyperemia of the iris, which hampers its movement. There may be an occlusio pupillae, where the pupil is completely occluded due to organization of the exudates across the entire pupillary area. Then we have the changes in the intraocular pressure, which is equally important. The IOP may just be very normal, or they may be increased. This may be because of the type of uveitis that we are looking into, or there may be a secondary glaucoma. In case of a severe anterior uveitis, there may be an acute ciliary shock, which can cause a decrease in the intraocular pressure, or in chronic cases have an atrophy of the iris process, which leads to a decreased intraocular pressure. The changes in the lens that are noted are basically the pigment dispersion on the anterior lens capsule or the development of complicated cataract later on. The changes in the posterior segment, that's the vitreous and the retina, are basically presence of inflammatory cells in and exudates in the anterior vitreous in case of severe acute anterior uveitis, and or the presence of cystoid macular edema in chronic cases. We were talking about the keratic precipitate. Let me just elaborate these which we see on slit lamp. These are the commonest findings. And here we see they may be either fine or stellate KPs, which normally are very light and almost appear as endothelial dusting on the endothelium. They're commonly seen in Fuchs uveitis syndrome or hepatic iritis. They may be small or medium-sized, which are granular KPs, pathognomonic of non-granulomatous uveitis. They'll appear very dirty, whitish keratic precipitates scattered irregularly on the back of the cornea. Then we have the mutton fat KP, which are the pathognomonic of a granulomatous idocyclitis and are composed of epithelioid cells and macrophages. They are large, fluffy, and give a greasy appearance. The old KPs, which are actually in the process of healing, where they sort of shrink and they appear crenated and give a grounded glass appearance because of the hyalinization process. Now, another tool in the armamentarium we have is the confocal microscopy, which also aids in the understanding the keratic precipitates a little more, wherein there is the keratic precipitates on the confocal microscope has been identified with various morphologies like stippled, globular, dendritic, and infiltrative. Later study has shown where you can actually see the morphology and sort of categorize the keratic precipitates as belonging to an infective or a non-infective pattern. The stippled, globular, and the multiglobular pattern suggests a non-infective pattern, while the globular with dendrites and a pure dendritic pattern suggests an infective etiology. Now, here we have a patient. Here we have a case of a HLA-B27 associated uveitis, where the slit lamp shows fine keratic precipitates and a hypopyon in the slit lamp, and on confocal microscopy, you see the stippled keratic precipitates. And here, in a case of tuberculosis, that is presumed ocular tuberculosis, we have a large keratic precipitate on the endothelium, and the confocal in this case shows a central globular pattern with dendrites. And in case of toxoplasmosis, the anterior segment shows fine keratic precipitates, and on the confocal shows a central globular with a dendritic form of keratic precipitates. Similarly, in these syphilis, where you are seeing fine keratic precipitates on the endothelium, and the confocal shows a central globular with a dendritic form with infiltrative pattern. And in an anterior uveitis due to chikungunya, here the fine keratic precipitates which are seen on the slit lamp shows a dendritic pattern on confocal microscopy. Similarly, large KPs on a case of a sarcoidosis on confocal shows multiple globular patterns. So here we see the morphology on the confocal helps to differentiate the cases. The anterior segment OCT also in case of anterior uveitis can identify the keratic precipitates, fibrin deposition, corneal edema, and also shows the hyperreflective spots in the AC, which are the inflammatory cells. This, in the case of CMV endothelitis, what appears on slit lamp as whitish pigmented KPs and coin-shaped lesions on the ASOCT gives a sawtooth appearance and a high posterior corneal reflectivity. In a VZV anterior uveitis, where the patchy partial atrophic patch on the iris on the OCT shows a pass corresponding to the iris atrophic pattern. Now, very often in clinics, you find the patient comes to you with a whole lot of unnecessary tests done, positive results, incorrect diagnosis that leaves in a conundrum where exactly what is happening. The compliance of the patient is lost. There's another case where you're still struggling to pick the right test to do, And then you adopt a shotgun approach to order whatever possible causes. This is a common feature. Do not worry, you're not alone. This happens very commonly. Investigations cannot be just randomly advised, as you will just get nowhere with them. So what we have, the crux in diagnosing these cases of uveitis should involve what we call as a pattern recognition and a probabilistic method to identify the primary cause of intraocular inflammation, to ensure effective treatment, and also look for comorbid association of systemic diseases. Now, when we're talking about pattern recognition, here we see the first picture showing a diffuse pattern of keratic precipitates in an eye which has no posterior synechia, as in case of Fuchs uveitis syndrome. And while the second picture shows patchy iris atrophy in a case of a viral anterior uveitis. Now, second is the third picture shows a hypopion. Now, when you have a hypopion, there are probabilities are many. Now, here we have 3 patients of hypopion anterior uveitis. Now, this requires additional elaboration. Now, the first is the case of HLA-B27 associated anterior uveitis, while the second set is of a case of a Behçet's. Now, here there lies the importance of evaluating the posterior segment of the eye in all cases of anterior uveitis, not to miss out the findings on the retina, as is typically seen the Pern pattern on fluorescein angiography in Behçet's disease. History, the importance of history is again paramount again here in the third case, where there's a case of uveitis with hypopion in a case of post-operative endophthalmitis. So, hence, a detailed meticulous ocular and systemic history is very important, and a complete ocular examination, even in a case of anterior uveitis, is mandatory and will require a multidisciplinary approach involving the rheumatology and pulmonology colleagues. Limited role of lab investigation is sought in cases of single episodes of unilateral mild to moderate non-granulomatous uveitis, or when the clinical features are typical, as in case of Fuchs uveitis syndrome, or when the systemic diagnosis is compatible with the clinical findings, as in case of ankylosing spondylitis, in traumatic uveitis, or when we know that the clinical diagnosis of a lens-induced uveitis. And not one more is the drug-induced uveitis. So why do we need to investigate then? We need to rule out infections in order to avoid flare-up with steroids, which the choice of specific in the treatment to avoid side effects of medications. Systemic treatment look for systemic association, where we will need to involve our physician colleagues. Correct therapeutic approach to be adopted when the diagnosis is very specific. We should also keep in mind the masquerades, which often present to us as uveitis, whether it is in case of a lymphoma and sometimes even in retinoblastoma. So our protocol for investigations has to follow a pattern where certain things have to be done, like syphilitic test, treponemal and non-treponemal tests. We do that as a regular because they are great mimickers. And if we have a non-granulomatous anterior uveitis, we do the HLA-B27. And in case of a granulomatous anterior uveitis, TB or serum ACE has to be ruled out. Now, when you're suspecting an infectious etiology or a hematological malignancy, the complete blood count with SPEP have to be done. And when we are suspecting a systemic inflammation as a cause of uveitis, ESR and CRP is mandatory. When we have a case where there is uveitis which is steroid resistant or has elevated IOP, an AC tab should be planned to do the PCR, rule out viral etiology. We have a granulomatous inflammation with a positive or raised serum ACE level and chest X-ray. An HRCT, which we now actually do it as a first line, is advised. In a young patient with granulomatous inflammation, we must not miss out TINO and do this urinary beta-2 microglobulins. Granulomatous anterior uveitis in a TB endemic region. Rule out tuberculosis with the PPD test as well as the quantiferon TB gold. A patient comes to us with the associated history of insidious back pain, sacroiliac joint X-ray or MRI will clinch the diagnosis. Further evaluation with the help of our physician colleagues can be elaborated in cases of, like in case of sarcoidosis, where you want a bronchoscopy or EBUS done, where it would need to be referred to the pulmonology colleague, or there are neurological signs or a brain MRI may be required. Besides, we also have ocular fluids that also help us in the diagnosis of anterior uveitis, where ocular fluids like the tear and the aqueous humor can be are found to be helpful. Now, the tears, in the tears, we have cytokine levels of IL-6 and IL-10, and the ratios of the two found to be higher in the tear samples of HLA-B27 associated anterior uveitis, and the levels of IL-6 levels are found to be associated with active disease and multiple disease episodes. The aqueous humor, which we just, as I said, where we do the PCR to rule out infectious anterior uveitis when indicated. And in cases of ocular sarcoidosis, the lymphocyte subset analysis in the form of doing a CD4, CD8 ratios have been found to be higher in cases of ocular sarcoidosis. Now, this is a quick guide to testing. More important here, I want you to look at what you should not be doing in a case of anterior uveitis, that is doing the RF factor, ANA, and ANCA, unless you have associated peripheral ulcerative keratitis or scleritis associated with anterior uveitis. So an evidence-based approach is mandatory, neither a total empirical nor a totally lab-dependent approach, rather a middle path with utilizing pattern recognition and probabilistic method supported by the laboratory workup and ancillary imaging to help us manage these cases. Anterior uveitis treatment depends on the whether it's an infectious or a non-infectious etiology. In a non-infectious etiology, the topical steroids and cycloplegics are the way to go. Avoid using cyclopentolate in these cases. And in case of recurrent or chronic cases, you may require to step up medication to oral steroids or sometimes even immunosuppressive. Inadequate response and association of comorbidities may require use of biologic agents. In an infectious etiologies, specific therapy, anti-infective therapy with or without steroids may be the way to go. A certain point I would like to just highlight here. Anterior uveitis can be spotted easily for a good slit lamp examination by looking at the signs and symptoms, following a pattern recognition and probabilistic approach. Check patients with associated systemic condition in chronic cases, which may be otherwise asymptomatic. In case of blunt trauma, it's an acute condition and recurrence in such cases is very rare. Any 3 recurrent acute episodes with no explanations indicate a systemic cause. Now, a word on the steroids in anterior uveitis. When in cases of systemic association, the steroids have to have a very slow taper in case of GIA uveitis with a maintenance dose. In sarcoid cases, there requires a regular taper. In case of HLA-B27 related anterior uveitis, the tapering is based on the response to inflammation, while in case of Behçet, it requires a very careful titration. In case there is a coexistent contraindication to topical steroids, you need to have steroid sparing supplemented with topical NSAIDs and lubricants. And if there's a fungal uveitis or scleritis, they need a careful monitoring. Now, the response to treatment with steroids is very suboptimal if the case is of a Behçet's disease, which in most cases requires treatment with immunomodulatory therapy, not just steroids. With autoimmune diseases, it is optimal, and cases of sarcoidosis respond beautifully with steroids. Considering the acute versus the chronicity of the condition, a short acting steroid works well with acute uveitis and long-acting ones with chronic uveitis. Now, keeping in mind the pattern of uveitis, in case of JIA in particular, where there is a previous recurrence noted with a particular dose of on tapering, maintenance at a particular dose has to be maintained before the steroid sparing strategy starts working. And in viral uveitis, a specific maintenance dose of topical steroid once or twice daily for a few weeks with specific antivirals shall avoid a rebound of the inflammation and hence control inflammation in these cases. And with this, I invite any questions or suggest. Thank
Thank
you.
you, Dr. Namita Davi ma'am, for that comprehensive and beautifully vivid presentations. All the characteristic clinical pictures that you have shared are sure to stay with us. And after this talk, anterior uveitis will be very hard to miss.
Right.
I'd like to now open the floor for discussion and invite our expert panel to offer their valuable perspectives.
Excellent presentation, Namita. As always, actually, there's not much to add if you have an experienced person who's done uveitis for so many years presenting, and then like I don't think there's not much from our side to add. She had like very good images, so such a good flow actually. And obviously, she not just mentioned what to do, and she actually also told that what need not be done also. Like in anti-uveitis, sometimes like people keep doing so many things which are not part of the requirement at all for anterior, which never ever causes anterior. So basically, like as she said, just to summarize, probably like you can actually have about 3 or 4 different grouping of antirheumatis. I mean, like basically, either it can be a hypopion and organized coagulum, and depending on the content of the hypopion or the coagulum, or the granulomatous variety, or the fuchs or fuchs-like variety, and others. So any of the antirheumatis fits into any of these 4 groups only. So it has to be one of these 4 sets. So if it's like Fuchs or Fuchs like, especially for PGs, one thing they need to remember is that they may be asked in exams whether in which are the conditions where you'll have white eye and uveitis with raised IOP at presentation. So glaucoma can be part of uveitis or secondary glaucoma due to many reasons, but there are very few conditions where you have uveitis with raised IOP at presentation. So this is a group of conditions where Fuchs, viral, Posner-Schlossman, where these are the ones where you have uveitis, and they have other similar presentations also. They have iris changes. One can be sectoral, one can be diffuse. They can have scattered KPs all over. They can have unilateral. Some can be in more often in males. So that's a one set where you need to rule out. When in doubt, even if you find a single pigmented KP in a scattered KP presentation, then probably it's not Fuchs. So it has to be, everything has to be white KPs. So Fuchs is the only condition which doesn't typically fit into the granulomatous variety, but can have iris nodules. So otherwise, like iris nodules means it is granulomatous, the typical granulomatous. So like that's all. Like antirheumatis probably it can be a hypopion or as she was telling, it can be so mobile in Behçet's that if if you are more interested in seeing the retina first and then the slit lamp, you make the patient lie down first and then make the patient sit up. The hypopion would have disappeared. You would have missed the transient mobile hypopion. It can be that transient in Behçet's. So if it's an organized thick hypopion, it's B27. It's a transient mobile, it's B51. So granulomatous, obviously you cannot, there's no SINACO and none of this disease in granulomatous. It can indicate TB, sarcoid, syphilis, and so many things. The 4th group is non-specific. It can be drug induced. It can be, if it's in extremes of age, it can be masquerade. Then it can be JRA, like herpes zoster ophthalmicus and things like this. So one of these 4 groups, only antirheumatis presents most of the time. So that's very nicely done, actually.
Yeah, excellent presentation with beautiful images. Yeah, most of it have been discussed. To re-emphasize, anterior uveitis be diagnosed mostly by slit lamp biomicroscopic examination. In monitoring the response, in addition to the diagnosis, we use the Sun classification by estimation of the flare in cells. The cells are more important in titrating the treatment than the flare, because sometimes if there is a breakage of the blood aqueous barrier, there will be persistence of flare in JAA-associated uveitis. So we titrate a treatment based on the amount of the cells present. Cells quantified by slit lamp biomicroscopic examination. The other method, like Dr. Namita showed, the ASOCT, where we can quantify the amount of the cells. In addition to that, there is a laser flarimetry, which can measure the amount of the cells present, that also can be used to monitor the disease or the quantification based on the imaging methods. Coming to the presentations, whenever we see a diffuse fine KPs, we think either it could be Fuchs or viral uveitis. The atrophic patches have been already described. The next comes iris nodules. So the copies present both in non-granulomatous and granulomatous, whereas the iris stromal ones, the busakas, present in granulomatous entities. If they have the same nodules present near the limbus, what we call it as a Berlin's, then we need to rule out sarcoidosis. So the next comes when afterwards, like, whenever we have to have different specific entities, like we told non-granulomatous, granulomatous, Fuchs uveitic syndromes. So in Fuchs, most often is underdiagnosed, overtreated with steroids. So we need to rule out viral infections. Most of them is non-specific, and also have to watch out for complications like development of the cataract and secondary glaucoma. In Fuchs, always there will be some amount of anterior vitreous cells will persist. Normally, we'll aim for complete resolution and then take up these cases for surgery. In Fuchs, it may not be possible. So even if the cataract can mature rapidly, in spite of having few anterior vitreous cells, we take them up for surgery in that case. So the next comes the drug-induced uveitis. Is important. We need to listen to the history. Patients must be having autoimmune disease. They must have taken a biphosphonate infusion last week and then come back with that. So when we look at it, we say the patient has recurrence, not responding to the treatment. We end up stepping up the systemic immunosuppression, but actually it's due to the drug. So once you treat them symptomatically, they will get better. So the next is the vaccines associated uveitis. We, especially in pediatric age group, we need to ask them the history. So this can be the triggering event for
You're not audible, ma'am. Mahima?
Yeah, I think
Yeah.
we lost connection to her.
We can proceed with Dr. Sudarshan sir's comments then.
Yeah. Thank you, Sudarshan sir, for your very valuable inputs and an engaging discussion. We now move on to the next talk with Dr. Vijaya Sahu, who will be talking on scleritis. Over to you, ma'am. You're on mute, ma'am.
Am I audible?
Yes, ma'am. All fine now.
Okay, thank you so much, AIUS and Santosh sir, for this opportunity. Today I have given a topic of scleritis. So there is no conflict of interest, and the content of this presentation has been taken from the various online sources. And as this lecture is for the postgraduate, so they should know something about the anatomy that helps in better understanding of disease pathology. So sclera is actually it comes from the Greek word that is scleros, that means hard. So sclera is considered as the hardest part of the eye, and it is a wide portion of the eye. It's opaque structure, although it has no active contribution in the visual function like other structures they have, like the cornea, lens, retina, uvea. But definitely sclera protect these all vital visual vital structures. So definitely it has a very important role. Embryologically, it has a similar origin like the corneal stroma and endothelium. So that it is originating from the mesoderm. So Uh, it's opaque and very resilient structure, and it is extending from limbus to up to the posterior optic nerve canal, and it contributes a 90% of our outer coat of the eye, and rest of the 10% is by the cornea. And the human cornea has a peculiar sclera, that is white color sclera. And why this happens? And this is because of the irregular crisscross arrangement of the collagen bundles. So there will be the scattering of all wavelengths of light, so the sclera looks white in color. In children, many times usually we see some bluish hue. That is because of the thin sclera. So underlying choroid hue can be visible, that gives a bluish color. And in older age group, we can see some blackish and yellowish deposits. That is a sign of aging, and that is because of the deposition of fat. And what is the relation of the sclera? Anteriorly, it is related to the Tennant's capsule for the whole length, and but in anteriorly up to the insertion of the extra muscles, the additional covering is conjunctiva, and posteriorly it is in close relation with the choroid. Like in this picture, we can see the purple one is a choroid and the blue one is a white thing is choroid. So there is a space between the sclera and the choroid, that is suprachoroidal space. This space has a now applied value because this space is utilizing for delivering some steroid for the chronic CMA. Now the thickness of the sclera, it is thinner in children and thinner in female as compared to male. And thickness is also not uniform in the whole entire length of the sclera. It is thickest near the optic nerve exit, that is 1 mm. And it is thinnest near the insertion of the extraocular muscle, that is 3 mm. Why it is important to know this? Because this thin area may be the site of globe rupture during trauma or in case of intraocular malignancy like in retinoblastoma. So this is microscopic picture of the sclera. The sclera has three parts. Another superficial one is the episclera, which is adjacent to the conjunctiva. Middle thickest one is the sclera proper, and the inner one is the lamina fusca, which is adjacent to the choroid, and it contains the melanocyte. That's why it is brown in color. So the blood supply of the sclera, it's supplied by the anterior and the long and short posterior ciliary artery. There is one peculiar thing about the episcleral blood plexus, that these vessels, they don't have muscular layer, but they have endothelium with basement membrane and discontinuous layer of pericytes, and they have peculiar thing, that is artery to artery anastomosis. So the blood oscillate in the circulation, and this is the basis why the sclera is usually commonly involved in the autoimmune diseases. Before going the scleritis, everyone should know about the vascular plexus in contrast with sclera. So there are three vascular plexus. Superficial one is the conjunctival plexus, which usually get congested in conjunctivitis, and you can see when you examine this patient in the bright red sunlight, that will be a bright red in color, and that will be easily blanched with a topical vasoconstrictor. The middle layer is a superficial scleral plexus, and it gets congested in episcleritis, and in daylight it gives like hue, they give a salmon pink in color, and it is also easily blanched with a topical vasoconstrictor. And the deeper plexus is the deep vascular plexus, which congested in become dilated in scleritis, and this gives a violaceous hue, and it will not blanch with topical vasoconstrictor. In this picture also you can see, this is no first one is a normal configuration, second is episcleritis, where only the middle layer gets congested, but in episcleritis, scleral thickness is normal. But in scleritis, along with the congestion and dilatation of all three vascular plexus, there will be the dilatation, swelling of the sclera also. And it is like similar to the cornea, it has very rich now supply through the long and short posterior ciliary artery, and this is the basis for the painful condition once sclera get inflamed. And so usually, as compared to other structure, disease of scleras are relatively rare because of its relative avascular nature. And second, once there is any insult, so its fibrous tissue usually show very less or lack reaction to that insult. But once any disease happens to the sclera, it will be chronic and sluggish. Why? Because usually there is a delay in the diagnosis, and because of its relative avascular structure, there will be the poor penetration of whatever available drugs. So inflammation of sclera, it was actually classified by the Watson and Hyre into the episcleritis and scleritis. Although these are the inflammation of same structure, but they have, their presentation is totally different. Like episcleritis, usually it's self-limiting and you hardly we require any systemic therapy. But in scleritis, always we require a systemic therapy. So now come to the scleritis. So scleritis is a severe painful inflammation of particularly middle layer, that is sclera proper. There will be the edema and cellular infiltration of the sclera and episclera also. And it is important because if you don't treat this condition timely and adequately, it can cause the permanent vision loss. So it is usually commonly affect the middle-aged woman in the fifth decade of life. Usually start from the one eye, but it can involve the other eye in around 50% of the cases. And if the condition become bilateral, that is a red flag sign that definitely this disease have a systemic association. So patient, the most common clinical feature will be the severe pain that will be insidious or dull boring pain. The pain is so severe that patient usually awakes from the sleep, and that can refer to the temple, jaw, and even teeth. So what is the pathogenesis behind this scleritis? So there basically it's a occlusive vasculitis, and occlusion is because of the immune complex deposition to the scleral vascular plexus, and it may involve any part of the eye, anterior or posterior, both. So first there will be the infiltration of the inflammatory cells like polymorphs, leukocytes, plasma cells, and macrophages, and there will be later on there will be the fibrinoid necrosis and ultimately destruction of the collagens. And you can, on microscopic examination, you can see the granuloma formation, which will be surrounded by the multinucleated giant cells and new and old vessels, and sometimes the vessels may show the signs of vasculitis. So what are the causes for scleritis? It can be idiopathic, it can be associated with some autoimmune diseases, metabolic diseases, some infection. It may be associated after the surgery also. So most common one is idiopathic. So what happened in idiopathic variety? So there is a disturbance in the equilibrium of the scleral specific antigens towards collagen and glycosamine glycan, and it will be mediated by the type 4 delayed type of hypersensitivity reaction. The second variety, which is most common cause, is systemic disease. So half of the patient of scleritis is associated with rheumatoid arthritis, and the reason, the pathogenesis is the immune complex deposition in the superficial and the deep plexus. Some it may be associated with some other diseases like Wagner's granulomatosis, polyangiitis nodosa, SLE, and ankylosing spondylitis. Some infective condition also contribute in the cause for the scleritis, like endogenous spread of infection from chronic staphylococcal and streptococcal infections. It may be associated with some viral infections like herpes virus infection, and some granulomatous infection like tuberculosis, syphilis, sarcoid, leprosy can cause the infection. And it is very important to differentiate between whether it is infectious or non-infectious. Why? Because the treatment is absolutely different. If like in normal situation, rest of the non-infectious condition, steroid is the mainstay treatment, but infectious variety, it is contraindicated. So that's why it is very important always to differentiate whether it is infectious or non-infectious. Usually infectious variety present with the pus point or yellowish things on presentation like in this picture. Third variety is surgically induced scleritis, usually we call it a SINS. So it is actually described by Aronson et al. In 1976. Usually this happens within 6 weeks after surgery, and the site of area of involvement will be near the scleral incision, and may be associated with some corneal involvement also. And this type of scleritis usually have a poor prognosis, and there is a high risk of scleral perforation. So now come to the classification of scleritis. So first we have to differentiate whether it is infectious or non-infectious. And non-infectious is further classified into like whether the scleritis is involving anterior to ora serrata or posterior to ora serrata. If it is anterior to ora serrata, it will be the anterior scleritis, and if it is posterior to ora serrata, it will be posterior. So luckily, anterior scleritis is most common type, and it is less severe form of scleritis. And this anterior scleritis is further categorizing on basis of presence of necrosis. If it is with necrosis, it is called as a necrotizing scleritis. If it is without necrosis, it is non-necrotizing. And this non-necrotizing is further classified into the diffuse and the nodular type, and necrotizing variety will be classified with inflammation and without inflammation, and posterior scleritis will be classified into nodular and diffuse variety. So anterior scleritis is the most common type, and out of this, non-necrotizing variety is very common, that is around 80%, and which is further classified into the diffuse and the nodular variety. And out of this, the diffuse variety is most common. So there will be a widespread inflammation of the sclera. It can involve more than one quadrant of the eye, and there will be the congestion of deeper plexus, which can easily you can access after application. We can find out whether it's a deep plexus involvement after putting a 5% or 4% phenylephrine. And patient may have photophobia with severe excruciating pain. So this is diffuse variety. Why I'm saying diffuse? Because in this condition you are not able to make out the boundaries. So that's why it is a diffuse variety. So in diffuse variety also, sometimes you may find some corneal involvement in form of some peripheral thinning, corneal infiltrations, and this is a red flag sign. If there is a corneal involvement, you have to look for the systemic association, and usually this will be situated near the limbus, and sometimes you may find the raised intraocular pressure along with the diffuse scleritis, and that is because of the involvement of the trabecular meshwork. So, and the second variety of non-necrotizing is nodular form. So nodular form is actually we consider the slightly serious as compared to the diffuse variety. Why I'm saying nodular? Because there is an area of slightly raised area of scleral edema with congestion of the scleral plexus, and this will be a bright red in color. And you with when you try to move with that sterile cotton tip applicator, there will be no movement. It will be immobile, and it will be tender on palpation. And this nodular scleritis when usually see with the help of slit lamp, like in the second picture, the anterior beam is clearly visible, but the posterior beam is not visible. So this is scleritis, not episcleritis. And but there will be no signs of necrosis in this non-necrotizing variety. Then second is necrotizing variety of anterior scleritis. So this is most severe form of the type of scleritis, and commonly we see this type of scleritis in rheumatoid arthritis patient, and 60% of the cases usually have a bilateral presentation. And the severe pain and the tenderness, that will be the out of proportion to the inflammatory signs, that is again going towards the necrotizing variety. So what happened in the necrotizing anterior scleritis? So patient will have this white avascular area of localized scleral edema and congestion, and the edge of this lesion have a very like more inflamed as compared to the center. And again this inflammation will be severe enough to cause necrosis of the sclera. And after some time, because there is a prolonged necrosis, this necrosed sclera become thinned out, and it become transparent and ectatic, and the uveal tissue will be shine through it, and the appearance will be like this. So blackish slightly area you can see at this moment, and anterior uveitis may found at this stage also. And the reason is again the vasculitis for this necrosis, which is secondary to the immune complex deposition, and there will be the result in the shutdown of the blood supply to the episclera and the vascular bed. If you don't treat this condition on time, this disease may spread circumferentially as well as towards the equator. So an entire globe can be involved, and ultimately there will be the total complete loss of vision. And end result will be like this: the patient will have a staphyloma in response to the necrosis. So in necrotizing scleritis, you may find the disease like vaso-occlusive disease like rheumatoid arthritis. You may find this condition with the granulomatous condition like Wagner's granulomatosis. You may also find the condition with the surgically induced necrotizing scleritis, most commonly seen with the tuberculectomy, especially if mitomycin is used during surgery, and it can be infectious also, especially with the Pseudomonas aeruginosa infection. Now come to the fourth variety, that is necrotizing anterior uveitis without inflammation, and it was discovered by the Vanderhue in 1934. And again, this is most commonly seen in the patient with a long-standing rheumatoid arthritis. But nowadays, incidence of scleromalacia purpurine is very less actually, because of the availability of very good immunosuppressant drugs. So the patients of scleromalacia purpurine will have a very minimal signs of inflammation or no pain. and that is the main feature that usually present comes to us. So in this condition, so what will be the presenting complaint that patient will come to your OPD? That will be a decreased vision. And why there is a decreased vision? Because of the thinning of the sclera, there will be the distortion in the size of the globe, and that will cause the astigmatism. So patient will have a diminished vision, and that is the thing that the patient will come to you. And there will be a progressive thinning, and staphyloma can be developed, but like this scleromalacia perforin, this is actually misnomer. Spontaneous perforation in this condition is not very common, but the rupture of the globe can happen because sclera become very thin. So even minor trauma can cause the rupture of the globe. So in along with the ocular sign, you have to look for the systemic sign like the joint deformity, some skin rashes, some skin rashes in the limbs also, and there's some deformity like in this is saddle nose and some old scar marks. So along with the ocular sign, you have to see the patient as a whole for to systemic evaluation. Now come to the posterior scleritis. So Peter Watson has a given very nice line that posterior scleritis is considered as a very most underdiagnosed and treatable condition in the ophthalmology, because its manifestation are so protein, and partly because we never think about the posterior scleritis. So that's why it is considered as a most underdiagnosed condition, and it contribute to around 2 to 12% among the all scleritis. So what could be the presentation in case of posterior scleritis? So similarly, patient also have a pain and tenderness, but an additional feature that patient may have a proptosis. So what could be the reason for the proptosis in this condition? So because in posterior scleritis, one, there will be the scleral edema, second, there will be the choroidal effusion, and third, there will be the subcollection in fluid collection, subtenons fluid collection. These things actually cause the slight proptosis in case of posterior scleritis. And if there is a macular involvement, the patient will have a significant vision loss, and there is a involvement of subtenon space, so patient will have a restricted motility, and can be the painful also. And because of the choroidal effusion, there it caused the anterior rotation of the ciliary body, so that caused the angle closure glaucoma like picture in the case of posterior scleritis. And in posterior scleritis also, there will be the change in the some refractive status, like there is a possibility that there will be the decrease in the myopia or increase in the hypermetropia. Means if patient is having existing, the like patient is using glasses, so there will be maybe the sudden change in their existing number. That can be also the presenting feature. So what are the presentation in case of posterior scleritis? There can be the macular or paramacular edema. There can be the choroidal folds. There only disc edema can be there. There will be the extensive exudative retinal detachments, choroidal thickening, or there will be the only optic nerve involvement with the peripapillary SRF. So the diagnosis of sclera, whether it is anterior, whether it is a posterior, it is clinical actually. So when patient comes to you with a redness and pain, severe pain, think about the anterior scleritis. And although in case of posterior scleritis, maybe patient have a less obvious sign, in that situation you may take help of the some imaging studies for the diagnosis. So remember 3 P's in case of scleritis: pain, purple, and persist. Pain, that is dull, boring pain, severe pain which awakes the patient from the sleep. Purple means when you examine the patient the daylight, so it gives a purplish or violaceous hue. And when you blanch or when you put a vasoconstrictor drop, it will persist. So these 3 P's are in favor of scleritis. Now come to the grading of the scleritis. Firstly, McCluskey and Wakefield has given a one scoring system. Later on, San et al. Has given a very good grading system. You can clearly see in like in the grade 0, there is a very no inflammation, and the vessels will be completely blanched when after putting a 10% phenylephrine. Grade 0.5, there is a minimal very trace inflammation, and there will be the localized pink appearance of vessels. And gradually there are +4 grade. In +4, there will be granulomatous and the diffuse scleral vessels with scleral thinning, and there will be the blackish hue you can see. So this grading system is very important for the practical purpose. Now, other ancillary tests which helps in diagnosis is a fundus fluorescent angiography. So there will be a pinpoint early leak with later on there will be the pooling of dye. It is very important, and actually it helps in differentiating from the VKH. In VKH there will be slightly early hypofluorescent. Later on there will be the hyperfluorescent. So this helps in differentiating from the VKH and the sclera. Another important ancillary test is ultrasonography or B scan, because there is a collection of fluid in the subtenon space. So that is a classical, gives a T signs. Although it's not a pathognomic, you in pen uveitis also you can find this T sign. But definitely if there is a other signs or history present, you can, this definitely help in making diagnosis. Another important test is OCT. So in the picture you can see the changes, undulation of RPS, some thickening of RPS, that actually helps in an presence of SRF. So OCT has a diagnostic as well as therapeutic role. So you can actually monitor the treatment with the B scan also, how it is reacting, how it is correct. Another ancillary test is CT scan. So in CT scan, you another additional finding that you can see the infiltration of extraocular muscles, and there is a ring sign of enhancement of the sclera that is specific for the posterior scleritis. So, what are the laboratory investigation for the scleritis? So, unfortunately, there is no single test is available which are diagnostic and specific for the scleritis, and there is no actually the battery of investigations for the scleritis also. So, the combination of your history, your clinical science, and some ancillary tests is actually helps in making diagnosis. And before, along with the in confirmatory test, there are some tests like CBC, ESR, liver function test, renal function test, blood glucose level. These tests are not for the confirmation of diagnosis, but these tests are actually the fitness of therapy, because the patient usually require the long-term immunosuppression. So these tests are a baseline. These tests are important for the regular follow-up, to just check the whether there is a side effect related to the immunosuppressant or not. So what are the investigation now? So in non-infectious variety, there are some tests, routine tests like ANA, C ANCA, P ANCA, X-ray spine, lumbosacral spine, MON2 test, CT test, or RA factor. These are the common tests usually we order in case of scleritis. And in case of infectious variety, always it is important to do a scraping of that yellowish pus things, and do microscopic examination under the gram stain and the KOH and colcofluoride stain, and the culture with blood agar and the chocolate agar. So that gives information about the macro or involved organism. So you cannot order all tests in all patients. That should be a tapered approach. For example, if patients comes to you with symmetrical joint deformity, morning stiffness, characteristic skin nodules, so that gives toward indicating towards a rheumatoid arthritis. So in this patient, just a RA factor will be sufficient, and the X-ray of joint. First, just come wait for these results and then order the other test. Similarly, if patient comes with the epistaxis, sinusitis, hemoptysis, that can be the vaginous granulomatosis, and the first order about the C ANCA and the P ANCA. Similarly, patient is having the acute painful swelling of any pinna, and there is a host of vice, that can be the relapsing polychondritis. So just order ANA and Cianca. And in case of like female patients comes with a photosensitivity, typical female face rashes, malar rashes, and some breathlessness finding complaint, in that condition that can be SLE. So ANA and NTDS, then DNA will be sufficient as the initial investigation. So in case of scleritis, your investigation should be tapered, and if first your first investigation negative, then you can ask for the next investigations. So now come to the treatment part. So the non-necrotizing variety, which is fortunately less severe form and most common form of scleritis, the first line is oral NSAIDs and topical steroids. And you have to taper topical steroids according to the disease severity. If patient not responding to this, then you can add a systemic steroid, that is again in the topic tapering manner. And if not, patient again, the system sign and disease is still progressing, patient is still complaints persisting, in that situation you can add immunosuppression after consulting to the rheumatologist. But in necrotizing, if you are seeing the white avascular patches and you are suspecting necrosis, necrotizing variety, in that situation immunosuppressant will be the first line of treatment to prevent the permanent or significant vision loss or significant structural changes. Is there any surgical treatment modality for the scleritis? Yes, there is a role in case of the severe necrotizing variety, when there is where there is a risk of globe perforation and there is a significant thinning of the sclera. In that condition, scleral patch graft can be done, and other patch like other donor like periosteum, fascia lata also can be used in place of the sclera. And this is essential to like integrate to control. This is not like just control the, it cannot halt the disease actually, just but prevent the disease eyeball perforation. So first you have to clean the area, clean the conjunctiva and the tendons over the staphylomatous area and expose the area, the affected area. And second, you have to cauterize a diathermy to shrink the staphyloma and also do the paracentesis so that you can push the staphyloma inside. And after the accurate measurement of the your affected area, you can place the your graft, that is sclera, with the help of suture or with the help of glue. And after that, scleroid tuck and properly fibrin glue is applied. And after that, the conjunctiva mobilized to cover the area where there is a shortage of tissue, we can apply the suture. So this is the surgical treatment for scleritis, especially the necrotizing variety. So when patient comes to you with just irritation and on bright red sunlight examination, it is a bright red in color, and after putting a topical vasoconstrictor, it's completely blank. So it is episcleritis, it is not scleritis. But when patient have a severe pain and it gives a purplish hue on daylight and it persists with topical vasoconstrictor, it is scleritis. So this is a schematic diagram showing the difference between the episcleritis and scleritis. So scleritis is very painful, a common condition which presented as a red eye. It is a sight-threatening condition, and especially and sometimes it may be the life-threatening also because of the systemic vasculitis. And local therapy is usually not adequate, and you have to give a systemic and long-term treatment. So proper counseling of the patient for the long-term treatment and persistence of the condition is very important. Thank you.
Thank you, Dr. Vijaya Dave, ma'am, for that well-structured presentation. You have highlighted all the key clinical points and practical management tips for scleritis extremely well, making them highly applicable in our day-to-day clinics as we manage this entity. I now would like to open the floor for discussion with our expert panelists. And now that we have her back with us, I would like to invite Dr. Padma Malini, ma'am, to kindly share her valuable insights.
Thank you, Dr. Vijaya Safi, for the excellent illustrative, simplified presentation. And she nicely highlighted the red flag signs, what we have to pick up in case of scleritis, and also the differentiating between episcleritis and scleritis, these diseases associated with scleritis. So it's most important whenever we see a patient with scleritis, we need to rule out underlying systemic disease. In majority of the times, it's associated with systemic autoimmune disease. They not only sight-threatening, sometimes they could be life-threatening. Yeah, conditions like vaginous, now it has been renamed it as GPA, granulomatosis polyangiitis. So there the patient presents with necrotizing scleritis. On evaluation, they can have sinusitis, renal involvement, and pulmonary involvement. In that situations, we go them with systemic immunosuppressives, IV methylprednisolone, or biologics. So that one entity we should not miss out whenever we see a patients with necrotizing scleritis. So the next, nicely, she pointed out the relapsing polychondritis. Most of the times when the patient presented with that, we may not have redness. So when we have to elicit the history, they might have had sometimes redness in the ears and the cartilage tenderness. That will help us to point towards the relapsing polychondritis. In rheumatoid arthritis, they have associated systemic deformities in the hand, joint pain. Those things will help us. So coming to the infective, the commonly we see in our part is tuberculosis can present with nodular anterior scleritis. The other conditions like, especially what are the differentiating points between infective and non-infective? The patient's presents with history of trauma, multiple nodularity of the scleral nodule with pus pointing. All this might point us towards infective etiology, where we do the scraping, microbiological evaluations, and put them on appropriate antimicrobial therapy, which nicely highlighted by Dr. Vijaya. So the next comes, in addition to the clinical evaluation, we also have to do a systemic evaluation. Then we do this grading. We follow different gradings are there. Depending on that, mainly we say whether anterior or posterior, necrotizing or non-necrotizing. Based on that, we choose the drugs. So coming to the posterior, most they can present it in the form of nodular posterior scleritis or a diffuse posterior scleritis. The one test is which is most useful to diagnose is B-scan ultrasonography, where subtenon fluid can present in the form of T sign. T sign need not be present in all the cases. Just the presence of subtenon fluid is sufficient enough for us to confirm the diagnosis of posterior scleritis. So the second thing is, she showed the nice picture, like, the herpes zoster ophthalmicus. They can present with recurrent scleritis. This is secondary to viral infection. So these are the things. In addition to the clinical evaluation and slit lamp biomicroscopic, we also can do a ASOCT, can help us to differentiate the depth of involvement and also can differentiate between episcleritis and scleritis. So we coming to the management, we straight away start them on treatment. After ruling out infective causes, we put them on topical steroids and systemic NSAIDs if it is milder form. If it is severe, associated with systemic autoimmune disease, we sometimes if it's necrotizing, we also go with IV methylprednisolone along with systemic immunosuppressive therapy like IV cyclophosphamide. Or now we started using recent biologics, either TNF alpha blockers or injection. Rituximab is commonly used in case of necrotizing scleritis, which is associated with systemic autoimmune diseases, especially necrotizing variety. Coming to the surgically induced necrotizing scleritis, it's a rare entity. But if they have patients with underlying autoimmune disease, if pre-existing inflammation is not sufficiently controlled, if you use a scleral incision and excessive use of cautery, these are all the triggering factor for the surgically induced necrotizing scleritis. Here again, we have to be aggressive. We follow the stepwise approach. Sometimes if you're not able to control the medical management, we end up doing the scleral patch graft as well, which has been highlighted by ma'am. Thank you.
Thank you, ma'am. Dr. Sudarshan, sir, would you like to add your remark?
Nice, very organized and informative. I think it was a very relevant talk. Like, all the relevant points are covered. And obviously, when she has covered everything and Padma spoken, not much to add that way. So I was wondering when she started off telling about anatomy, I was wondering why anatomy of sclera and scleritis. But then later on, you realize that how important it is to know the anatomical structure of sclera before diagnosing it as episcleritis, scleritis, or postscleritis, and where the inflammation actually occurs. So now we know ASOCT differentiates everything so well, but still it's so important to know the structure. So as Padma was telling, it's very important to differentiate infective and non-infective. That's the toughest part in scleritis. So diffuse, obviously she said when cornea is infiltrated, then it can be infective. But other than that, a diffuse scleritis is usually non-infective. So when I start scleritis, I keep thinking that if it's a diffuse scleritis, I'm relatively safe. Like it's probably non-infective. If it's a nodular scleritis, then you're stuck. Like you wonder whether it's infective or non-infective. Clinically, a subtle way of differentiating is if it's a firm or a hard nodule, then probably it's not infective. If it's a cystic type of nodule or multinodular, as she said, then it is probably infective. So usually the firm and hard ones can be masquerade, but it may not be infective. So that's a important point. One of the pictures she showed was of a conjunctival necrosis. So sometimes you shouldn't miss out a conjunctival necrosis or a pus point. They look little similar. In a pus point, you might have the blood vessels running over that yellowish tinge lesion, which she also showed. But a necrosis is something where you don't have that point tenderness and things like that. So it's important to differentiate those two. That's very important. Among the misnomers, other than Wegener's, I always keep thinking about this scleromalacia perforans. I don't know how they named it as scleritis without inflammation. They probably meant there is a lot of inflammatory signs but less symptoms. So I don't know initial classification when they made it scleritis without inflammation. It is there is significant inflammation in that probably, but maybe it's no longer used that often nowadays that way. And T-non space widening again, yeah, obviously that is enough. T-sign is not always required. You can sometimes have panscleritis. You can have anterior and posterior also, as in herpes zoster ophthalmicus. They can have viral infections can have both anterior and posterior ileum folds, which can mimic posterior scleritis. But otherwise, it's quite comprehensive.
I would like to
Posterior
mention one
scleritis
ATP.
is, yeah.
Yeah, please go ahead.
Now, posterior scleritis, I was wondering like whether FFA is so typical in scleritis as she said. Like many times it's very difficult to differentiate between all the three. Posterior scleritis, VKH, and sympathetic ophthalmia. So you can many times make out if it is not recurrent after a long time, if it's only unilateral, and if there is no anterior uveitis presentation at all after a long time, then you are very sure that it's not, VKH or anything like that. Like if it's unilateral, always with posterior. But otherwise, it's very subtle sign in posterior scleritis. It's easy to make out. VKH invariably will become granulomatous panuveitis later on.
Yeah, one more rare entity can present with multiple nodularity with firm. The patient is not very symptomatic, where where we do a excision biopsy, and immunohistochemistry confirms the case of a Rosai-Dorfman disease. It's a very, very rare. Off late, we started seeing these entity more.
Thank you, ma'am. Thank you, sir, for enriching us with your valuable perspectives and insights. And for the last talk of the session, it is my pleasure to invite Dr. Nitin Kumar for his talk on decoding intermediate uveitis. Over to you.
I'm trying to share my screen.
Yes, please go ahead, sir.
But unfortunately, it is telling me to quit and then reopen Zoom.
So please go ahead and do that.
Do you have the green button on the bottom 6 o'clock, doctor?
No, he's getting a prompt to quit and
So 1
reopen.
minute, I'll just reshare.
So you go ahead and reshare till then I'll address a question from the audience side. No worries, sir.
Sure.
So the question is open to Padma ma'am and Sudarshan sir. The question is that if at all you are getting ANA positivity in one report and you're getting ANA negativity in one report for a patient with recurrent nodular scleritis, what would you consider? And you can take this question now or later, but
So you can click the allow settings on the screen first, then you can proceed, please.
Is it now visible, my
Yeah,
screen?
can you just allow the settings on the screen, what you're getting? Just click allow,
Uh,
the prompt which is there.
so actually the allow prompt is
no, the prompt
underneath
is not coming.
it's underneath your presentation probably.
It's on the screen.
It's not seen to him.
Yeah.
Yeah.
I think it's
I'll
okay
take
now.
that question later. Please, sir, go ahead.
Yeah. At the outset, I'd like to thank AIOS for giving me this opportunity. And the topic which has been allotted to me is decoding intermediate uveitis. I do not have any conflict of interest. There is no financial interest in any of the product which I will show in this presentation. And I also want to acknowledge that there are some animations which are AI generated. As the previous speakers have also highlighted that uveitis is typically the inflammation of the uveal tract, but we saw two presentations. We are going to see two presentations where typically the choroid is less involved, like the previous presentation, sclera, which is not a part of the uvea as such. And I'll just say that the inflammation which involves iris, ciliary body, vitreous, choroid, and sometimes retina also has been labeled as uveitis. As far as intermediate uveitis is concerned, it is not a disease as such. It's not a single clinico-pathological condition. It's a diagnosis. And as previous speakers have also highlighted, it's the based upon the localization of the inflammation, where the primary source of inflammation is there inside the eye. As far as intermediate uveitis is concerned, the primary localization of the inflammation is in the vitreous, with some part of the posterior ciliary body involved, and the peripheral retinal vessels, which are involved uh, in this diagnosis as such. It accounts for about 15% of the uveitis cases which we see in our clinical practice. Coming to some historical aspects, it was 1908 where Ernst Fuchs first described this entity as chronic cyclitis. In the 1950s, it was further described as a peripheral uveitis by Stephens, where the peripheral retinal changes and executive changes were described by him. In 1960s, Brockhurst and colleagues described this entity again as a peripheral retinal vascular abnormalities. Later, Welch and colleagues coined the term sparse planitis. So as we see, there have been multiple synonyms which have been used for this diagnosis, like chronic posterior cyclitis, hylitis, vitritis, peripheral exudative retinitis, cyclochorioretinitis, and peripheral uveitis. So use of all these synonyms have just been a source of confusion among the various ophthalmologists dealing with this disease entity. However, as previously seen in almost all the slides, IUSG's International Uveitis Study Group tried to classify all these diseases into, tried to classify all the various manifestations of the uveitis, and intermediate uveitis has been described as an entity where typically the vitreous is involved and the posterior, that peripheral retina is involved. It includes pars planitis, posterior cyclitis, and hylitis. Coming to the epidemiology, about in the referral clinics, 4 to 8% of the cases of uveitis which are seen are the cases of intermediate uveitis. And it is a very common entity which is seen in the pediatric population, with almost 1/4 of the pediatric uveitis cases being a intermediate uveitis kind of a picture. Again, the disease is bilateral in about 70 to 80% of the cases. There have been various studies which have tried to associate whether there is a typical HLA association with this disease, and various studies have come up with different type of associations like HLA-DR15, HLA-DR17, A28, 51, and B8. It has also been seen that identical twins may have increased incidence of IU, and also this disease can sometimes run in family, leading to a genetic predisposition of the disease also. What are the common symptoms with which these patients present to the OPD? This is one of the most common symptoms is floater. The patient will present with some blurriness also, and also in very less number of cases there can be eye pain also. This is to highlight here that some of the cases may not have any of the symptoms and can be detected on a routine ophthalmological examination. These are generally those cases which have a very mild kind of a disease and are detected incidentally. What are the signs with which these patients present to us? Anterior chamber cells can be present. However, they are always less in number as compared to the vitreous cells, which is the second finding. Vitreous cells and vitreous haze. The cells can collect in the vitreous and lead to a haze obscuring the vision of the posterior segment of the eye, the retina. Then there can be these inflammatory exudates overlying the pars plana region, and some findings which are typical of the intermediate uveitis or a pars planatis like of a picture are snowballs and snow banking. What are these snowballs? These are the collection of inflammatory cells in vitreous and are typically seen in the inferior vitreous due to the collection due to the gravity. Again, the inflammatory aggregates which collect in the inferior pars plana region are known as snow banking. As previously highlighted, these patients can have involvement of the peripheral retina, which is in the form of a peripheral retinal vasculitis, which is typically a phlebitis, and in some cases, the arteries can also be involved, leading to a periarteritis kind of a picture. When the disease has been severe or long-standing, there can be neovascularization at the level of these snow bankings, and posterior segment can also be get involved, leading to optic disc edema in severe kind of disease. The other clinical presentations, the patients can also present with a complicated cataract initially to us. There can be glaucoma, chronic macular edema, and in some, again, if the patients are presenting late, there can be retinal detachments, which can be a tractional retinal detachment, a rhegmatogenous detachment, which has occurred due to the formation of a break due to the continuous pull of the organized snow banking, and in other cases there can be a vitreous hemorrhage, which all these complications are due to the neovascularization which takes place at the level of the snow banking. So just a pictorial representation of the various signs which can be seen in these patients. So if we see this slide, the posterior segment of the eye is is not visible clearly. So there are these sheets of the cells in the vitreous. These are the vitreous cells. The vitreous cells can be just a few in number or as intense as seen in this picture, leading to different grades of vitreous haze. So these vitreous haze was first classified into various grades by Newson-Blatt. And if we see these pictorial representations, we can see that the grade 0 is when there is no evidence of any vitreal haze and the posterior segment can be easily visualized. However, if there is mild blurring of the optic disc margin due to the presence of the vitreous cells, this is labeled as trace or 0.5. In other cases, when there is obscuration of the view, but still we are able to see the optic disc and blood vessels, that is labeled as grade 1 or score 1. Then score 2 is when there is obscuration of the view, but still we can see some of the retinal vessels. Grade score 3 is when the optic nerve head is only visualized and the retinal vessels are not visualized. And if grade 4 is when there is total obscuration of the fundus view and we are not able to see any of the structure. So if we go back to the previous slide, we are able to, there is a lot of vitreous haze, but still we are able to see the optic disc, some margins of the optic disc. So this comes under the score 3 of the vitreous haze. This is one of the patient who presented to us with some floaters, which is the most common symptom of the patients. And if we see in the inferior periphery, there were these clumps of the vitreous cells, which are known as the snowballs. Then what is snow banking? Snow banking is when all these inflammatory exudates collect at the inferior pars plana region and pars plana region due to the gravity. This is known as the snow banking. It has been generally seen that the snow banking is in the inferior part of the eye with the due to the gravity, but however in very severe cases the snow banking can be there in 360 degree of the retinal periphery in the pars plana region. This is a very nice pictorial representation which I have taken from the retina image bank. This shows the snow banking, the vascularization of the snow banking. These are all complications which can occur if the disease is not treated properly, and if there is suboptimal treatment, these kind of complications can occur, and these complications can also occur when the disease is very severe. Again, if we see in this pictorial representation, this is the sheathing of the vessels, which is the peripheral vascular involvement. And in the later phases, there can be exudative component leading to the formation of a exudative RD, or the tractional forces come into vogue, and there is the formation of a tractional RD also in some of these cases. So what is the pathology and pathogenesis of intermediate uveitis? Various studies have shown that, and the literature shows that there is a peripheral retinal phlebitis, inflammation of the retinal vessels in the periphery of the retina in the ciliary body region, which lead to the breakdown of the blood-ocular barrier and release of inflammatory cells, cytokines, and inflammatory mediators which settle down inferiorly and form snowballs as well as snow banking. Other studies have also tried to see what is the pathology of this disease. And although very few cases, but they have been able to histopathologically see that in the samples of the histopathology of the eye, that they have been able to demonstrate periphlebitis, perivasculitis, and they have shown that there is a perivenular cuffing and infiltration by the inflammatory cells, which are predominantly T lymphocytes. Some researchers have also studied the vitreous samples and have documented that epithelioid cells, multinucleated giant cells, infiltrate the vitreous in case of a intermediate uveitis. Snow banks, they constitute collapsed vitreous, blood vessels, fibroglial cells, and again, predominantly T lymphocytes. So what does induce this retinal phlebitis or breakdown of this blood ocular barrier? It has been shown that the disease starts to occur because of antigenic response, which can be due to an infectious agent or in autoimmune diseases as such. So what are the various causes for these for intermediate uveitis? These include tuberculosis, which is very common in our part of the country, leprosy, syphilis being a great masquerader can cause any kind of uveitis and is implicated in intermediate uveitis also. There are some rare entities also like Whipple's disease, STLV1 infection, cat scratch disease, and Epstein-Barr virus infection, which can produce a intermediate uveitis. Other non-infectious autoimmune kind of diseases include sarcoidosis, multiple sclerosis, which is very common in the Caucasians, and inflammatory bowel diseases can also present with the intermediate uveitis. Another disease entity which is a common cause is tubulointerstitial nephritis with uveitis. In addition to these causes, there can be some other diseases which simulate an intermediate uveitis kind of a picture. These include primary vitreoretinal lymphoma. A gray vitreous hemorrhage can sometimes be misdiagnosed as a intermediate uveitis. As previous speakers has also highlighted, fuchs heterochromic uveitis is very common entity which is commonly misdiagnosed as intermediate uveitis and treated with steroids. So it is very important and pertinent to see for specific signs of Fuchs heterochromic uveitis and rule out this disease in comparison to a intermediate uveitis. Endogenous endophthalmitis can also sometimes simulate an intermediate uveitis. Workup includes history and specific questions. We cannot ask so many questions also. Unrelated questions should not be asked, as they may cause more confusion rather than doing any good. So the specific historical questions should be asked after having a look at the eye of the patient. After doing a good slit lamp examination, a fundus examination with indirect ophthalmoscopy, we should ask specific questions. And then there should be a specific review of systems and tailored approach to the labs, which have been highlighted by all the speakers and panelists in this session. The labs should be pertinent. We cannot ask for all the labs in the uveitis workup. So a good clinical examination, specific history, review of system, and pertinent labs will help us to achieve diagnosis in almost 80% of the cases of uveitis as such. So if you are suspecting that the patient has some myeloproliferative disease, you can ask for a complete blood count, which otherwise also is asked in most of the cases in uveitis. If you are suspecting tuberculosis, you see those snowballs and patient is from endemic country, ask for a Mantoux test and relevant radiography. Get a chest x-ray. If you are not able to get CT, at least get a chest x-ray and look for those hilar, that lymphadenopathy, which is specific to tuberculosis. Rule out syphilis in all cases, as I have already previously highlighted. Syphilis is a great masquerader and can present in any form. Multiple sclerosis, which I think is slightly missed, is underdiagnosed in India. We don't do much of testing for multiple sclerosis, but it is very common in the Western world. And there are some signs which are specific to multiple sclerosis. As far as the clinical examination is concerned, it has been documented in studies that in patients who have multiple sclerosis will have more severe anterior segment inflammation, more severe kind of a pars planitis kind of a picture with dense vitreous, these snowballs and snow banking. And if these patients have any neurological symptoms like a foot drop, history of foot drop, or some kind of a demyelinating disease, then they should undergo MRI. Again, if the patient is from a endemic area and has typical this rash, so these patients should undergo Lyme serology, or we can do a serology for Borrelia also. Sarcoidosis is another entity which commonly presents with intermediate uveitis, and in these kind of patients, if there is a specific history, there have been other telltale signs of sarcoidosis in the history or on the clinical examination, then we should get a serum ACE, lysozyme, and CECT chest to look for the typical hilar lymphadenopathy which is seen in these kind of patients. So it is again emphasized here that the workup should be based upon the clinical findings and clinical history with a good review of systems. If in spite of doing all the tests, we are not able to get any positive tests, then one of the entity which has been very has been told by the various authors is pars planitis. It is idiopathic, which is more of a diagnosis of exclusion after we have excluded most of the causes of intermediate uveitis. It is one of the most common subtype of intermediate uveitis. Again, it is about 80% of the cases can be bilateral, and it involves the younger population. And most common cause of pediatric intermediate uveitis. It is also again emphasized here that these kind of patients will have a more severe type of a snow banking and peripheral vascular sheathing. We have seen what clinical tests we have to do, what lab workup we have to do. There are certain ocular imaging also which we like to do in our patients who present to us with the intermediate uveitis. These include fundus photography to document the vitritis. This will give us a clear that we can just document what was the vitritis when the patient came to us. Is he worsening? Is there any increase in the vitreous cells, or the patient is responding to the therapy? So we can document whether with the help of a fundus photography. We also like to get fundus fluorescein angiograms for our patients to document a peripheral phlebitis or the development of cystoid macular edema, which is very common in these patients with intermediate uveitis. OCT, being a non-invasive test, can be done instantly in OPDs to document cystoid macular edema or the complications of intermediate uveitis like a epiretinal membrane. Sometimes the patients may present with a severe vitritis or a vitreous hemorrhage or a retinal detachment, which can be assessed with a ultrasonogram. In patients where there is very severe inflammation and there is some hypotony also, we generally like to get a ultrasound biomicroscopy to see the status of the ciliary body. I'll just go through some cases to highlight what we have seen in the past few slides. So this was a 50-year-old male who presented to us with bilateral diminution of vision. He presented with 636 vision in both the eyes, and when we examined the fundus, there were presence of these snowball opacities in the vitreous. Again, as I highlighted, we did a angiogram and OCT on the same day, as we were seeing some dull foveal reflex in both the eyes. And although it's not very clear because there was some cataract also which had developed in his both eyes, but there was presence of these large cystoid spaces with subfoveal serous RD. And on the angiogram also, there was presence of this typical petaloid pattern with some inflammation of the optic discs as well as the peripheral. There was some phlebitis picture also. So we asked specific history. There was history of patient had a contact of TB in the family, and we did a Montu test for this patient, which came out to be positive. Performed a CECT chest for this patient, which was again suggestive of tuberculosis. So this is typical case of a tubercular intermediate uveitis. We started the patient on anti-TB treatment with concomitant oral steroids, and as this was a bilateral disease, and we can see that over the follow-up there was this reduction in the cystoid macular edema, and patient's visual acuity improved to 6/12. Coming to the case second, this was a 25-year-old female who presented to us with unilateral diminution of vision. This was in the right eye for last 1 month, which was gradual and progressive in nature. But if we see on ocular examination, there were no cells in the anterior chamber, no flare. And if we see at the posterior pupil, again, there was some vitreous haze. There was some foveal, we were not able to clearly see the fovea, though foveal reflex was dull, as compared to the left eye, which had a crisp foveal reflex. So there were presence of these vitreous cells, this decreased in vision, and again we did OCT for this patient, and you can see that there were presence of this cystoid macular edema with early ERM formation. And the angiogram again revealed the presence of a cystoid, this petaloid pattern suggested of a cystoid macular edema, and again there's some periphlebitis in the periphery of the retina. We did an extensive workup for this patient, asked specific history. There were no pointers in the history, no history of any TB, no history of any other systemic illness. We performed some of the relevant tests and they also came out to be negative. So we ruled out infectious and non-infectious etiologies for this patient and proceeded with a local therapy. So as this was a unilateral involvement, we injected dexamethasone implant for this patient, which can be seen in this photograph. And she required 2 dexamethasone implants over 2-3 months. And we can see that how she responded to therapy, and somehow this ERM also disappeared during the course of the follow-up of the patient. So this was a typical case of a idiopathic intermediate uveitis in which we were not able to find out any specific etiology, but we treated the patient based upon her clinical presentation and symptomology. Another patient was a 75-year-old male who presented to us with first episode of uveitis at such a age. He was 75-year-old and he presented with this diffuse, the decrease in vision. There were presence of few cells in the anterior chamber. There was some flare, creatic precipitates were also seen. But there was no congestion. And there was this dense vitritis. Only discs could be visualized. So in such situations, when there is first presentation of uveitis at a very extreme of the age, there are these sheets of vitreous cells, there is strong suspicion of masquerade. Again, as we can see, this was at presentation 3/60 vision. We could not see the posterior segment, only the disc was visible. So in this patient, we performed a pars plana vitrectomy to clear the media as well as to retrieve the vitreous samples for biopsy. We can see that after vitreous biopsy, there was significant improvement in the clarity of the posterior segment. And simultaneously, as we were suspecting masquerade, and the patient had some kind of a neurological deficit, we got a neuroimaging also done. So we could see that there was a huge lesion in the brain of the patient, and simultaneously our samples also came out to be positive for large B cells in the histopathology. This is the follow-up of the patient. We can see that after vitrectomy, he improved to 6/12. And this is at 3 months of follow-up when both the eyes underwent vitrectomy, and the vision improved, and we could institute therapy from both radiotherapy point of view for the systemic management of the disease also. So as we have seen already in few of these slides, I just come to the treatment strategies which can be employed in these patients. Topical steroids, although are not very much indicated, as the disease is primarily in the vitreous, primarily localized to vitreous. But if there is some spillover anterior uveitis, you can treat these patients with topical steroids. Periocular steroids in the form of a subtenon injection are indicated in cases of unilateral disease. Intravitreal steroids, although are indicated, but these are known to increase the intraocular pressure and should be used only when you have ruled out infectious causes. Intravitreal steroid implants similarly first rule out infectious causes, and then only these kind of interventions should be done for unilateral disease primarily. Oral corticosteroids are indicated in patients with bilateral disease, and as have been highlighted by the panelists also in previous talks, that these patients who require long-term steroid therapy have to be kept on long-term steroids because of the relapsing course of the disease may require a immunomodulator kind of a therapy. So various immunomodulators which can be used include cyclosporin, azathioprine, methotrexate, mycophenolate mofetil, and in children, biologicals have been used with great efficacy. Cyclosporin is the first line therapy because it has been seen that they have a good T cell inhibition, and T cell lymphocytes are implicated in the pathology as well as the pathogenesis of the disease. The management of, as previously also highlighted in slides, that 1/4 of the pediatric cases are pediatric intermediate uveitis cases. So a step ladder pattern have been proposed for the treatment of these patients, where if the disease is primarily unilateral, first we can try periocular steroids. Second step is to, if periocular steroids are not helping much, then we can start these patients on oral corticosteroids, and immunosuppressive therapy may be needed if patients have a relapsing remitting course of the disease. And in patients who develop complications secondary to intermediate uveitis, surgical management may be required. What are the surgical interventions which can be done in patients with intermediate uveitis? One is laser photocoagulation. So this is generally indicated when there is development of a retinoschisis or there is a localized RD developing. In those cases, laser photocoagulation can be done. Again, when there is peripheral retinal ischemia due to this persistent retinal periphlebitis or periarteritis, in these kind of patients, if neovascularization is developing that in the periphery of the retina, again laser photocoagulation is indicated. Cryotherapy also, although previously historically it has been used in large number of patients with intermediate uveitis, nowadays clinicians are not using much because it can itself have complications like the contraction of the vitreous base leading to the formation of RD. However, previously it was indicated in patients who had a vitreous-based neovascularization or a vasoproliferative kind of a tumor kind of a condition developing. Vitrectomy is indicated in severe cases of intermediate uveitis, like I showed in one of the case example, where the vitritis is so dense that we are not able to see the posterior segment. In those kind of cases, vitrectomy is indicated, or when the complications have occurred, like a tractional RD is formed in those cases, or in which a persistent neovascularization has led to a vitreous hemorrhage. In those patients, vitrectomy may be indicated. As highlighted previously also, complications can be common if the disease is persistent and is inadequately treated. These patients can land up in complications due to disease process itself. Cataract is very common. 60% of the cases can have cataract. Again, glaucoma can be there, macular edema. If long-standing macular edema is there which has not been treated, there can be a foveal atrophy. Peripheral retinal neovascularization can be common in cases of severe intermediate uveitis with a snow banking kind of a picture. Vitreous hemorrhage can develop. Tractional RDs, rhegmatogenous RDs, exudative RDs, choroidal detachments can also occur in the late phase of the disease. The therapies itself can lead to complication in some cases, like if periocular steroids are used, there can be a conjunctival scarring, conjunctival edema, glaucoma, and cataract is again common when periocular steroids are given. Intravitreal steroids again can lead to a IOP rise. Implants can lead to cataract, glaucoma, and we all are well versed with the various side effects which can be there with the oral corticosteroid therapy, and immunosuppression also can lead to very severe side effects and sometimes this life threatening side effects also. So whenever these patients are on these oral corticosteroids or immunosuppressive therapy, it is very important to counsel those patients and monitor for these side effects to get pertinent labs which can help us to identify whether these patients are developing these side effects. And again, these should be done in conjunction with in a team approach with the rheumatologist being in your team. What are the prognosis of these patients? So Brockhurst and colleagues divided these patients into five groups. And the group 1 was where there are minimal signs and symptoms, and these patients do well and sometimes may not even require any kind of therapy if the vision is good and there are not much of symptoms. Group 2 is when there patients which develop choroidal and exudative RDs, they have generally a poor prognosis. Group 3, where there are vascularized snowballs, cyclitic membrane, and glaucoma. Glaucoma is documented. Again, this group also does not do well, and there can be some other patients which develop optic atrophy. Again, they don't do well. And if group 5, where this disease keeps on smoldering for long periods of time and lead to various complications as enlisted in the previous slides. So to conclude, IU is, again, I highlight that it is not a single disease entity per se, but it is a heterogeneous groups of diseases. It is more common in pediatric population. Majority of the cases may be idiopathic, but still it is very important to do pertinent labs and to ascertain etiology, as it will help us to institute specific therapy, and treatment is generally aimed to prevent any prevent the occurrence of complications. These are some of the references, and I thank you so much for your patient hearing.
Thank you, Dr. Nitin Kumar, sir, for that vivid presentation enriched with highly informative images, AI or not. The way you have translated a complex topic such as intermediate uveitis into clear and easy to understand concepts with the help of case presentations also will certainly help everyone watching to approach this condition with greater confidence. At this
Thank you.
point, I would like to welcome our panelists to share their interpretations and practical viewpoints.
Dr.
Thanks,
Nitin.
Mahima. Can I go first? I'm
Sure,
sorry.
sure.
Sure, ma'am.
Yeah, hi. Good evening, everyone.
The important thing is even I get confused. Yes, Samshira.
Yeah. So, Nitin, first of all, just an amazing talk. It was like listen. Congratulations on a wonderful lecture on intermediate uveitis. So, from the practical tips, Mahima, as you very correctly pointed out, what is it that both ophthalmologists should take from this, or those who are managing these cases, whether they retina specialists or uveitis specialists? So, what I've seen in practice is when patients get referred to us. So these patients are started on oral steroids. The patients get better. Then again, they go back with recurrence, and again, they started on oral steroids. So the main problem is that early institution of immunomodulators, which Nitin has pointed out, is very important in these cases. So that decision is not taken. And as Nitin has very beautifully mentioned, that these cases have reactivation of the inflammation again and again because it's sort of idiopathic. We don't know why. So these patients need to be early onboarded onto immunomodulators. That is my main point that I would like to make. Thanks.
Thank you, Dr. Nitin. It was an excellent presentation. You have covered almost all points. To re-emphasize, whenever we see a patients with intermediate uveitis, we most of the times they presents with a quiet eye. Anterior segment may be quiet, and we check whether it is unilateral or bilateral, whether it is associated with any systemic disease like what you highlighted, like tuberculosis, sarcoidosis, multiple sclerosis, or other entities, or rarely infections like Lyme's, or it is idiopathic entity. Based on that, we start a regimen. Recently, the modified Kaplan is the one which, we tend to follow. If it's unilateral, we give either periocular intravitreal steroid injections or implants. If it's bilateral, we start with oral steroids. Like Dr. Somushila said, we go for the systemic immunomodulatory therapy. Most of the times, it is chronic they present with. So FFA definitely plays a role to map out the areas of the CNP, and if they have associated peripheral retinal vascularizations, we do them with targeted laser photocoagulation. Or if they have any associated complications like peripheral retinoschisis, also we do a laser photocoagulation. Rarely they can present with vasoproliferative tumors. In that situations, the cryotherapy of the periphery plays a role. The commonest complication in intermediate uveitis is the cystoid macular edema. We treat the disease automatically. The macular edema also has resolves. Nicely, Nitin pointed out with his case examples where he has put the intravitreal dexamethasone implant. Not only the inflammation has come down, the edema, cystoid macular edema, and also the reduction of the epiretinal membrane also is nicely he demonstrated in his case example. So this is we see the patients based on that, we plan the therapy and watch out for complications. In severe cases, or they have now biologics also as play a role in controlling the inflammation, but many of our patients cannot afford. Before instituting a biologics, it's important that we need to rule out multiple sclerosis. Otherwise, it will worsen the multiple sclerosis entity. Now, Janus kinase inhibitors or JAK inhibitors are also is useful in treating intermediate uveitis patients in pediatric age group. Thank you.
Thanks, Padma. Quickly, a few points. It's not mine. Basically, for the clinical aspect of it, how to differentiate the cells. So I was actually amazed in one of the webinars, Dr. Professor Amod Gupta had mentioned how to differentiate the cells, whether they are like intermediate uveitis or malignant cells or something. So sometimes, say he had mentioned, I'm just like quoting him. malignant cells tend to be larger, according to him. Something like in retinoblastoma, or there is a mix of both inflammatory and lymphoma cells in lymphoma. So if you find a lot of cells without much vitreous haze in an elderly, so probably you're dealing with the masquerade in intermediate uveitis. But if you have a lot of vitreous haze along with the vitreous cells, then the inflammation is because of the protein leakage, and so probably it's inflammatory. So this is one way to differentiate based on the vitreous cells itself, according to him. So usually in masquerade, he says AC reaction is generally absent. That's what many times you would have tried AC tap and cytology wouldn't have picked up any of the malignant cells. So if you have some RBCs here and there, then probably you know that it is actually hemorrhagic, and there is a streak of hypopyon also. If it is there, then probably these are indicative towards a masquerade, not an intermediate uveitis. So that way, sharp and large number of cells with it is, then your inflammation, but not much with vitreous haze, only cells more, then probably you're dealing with something else, or an IU-like picture, maybe in Fuchs, or even RP sometimes can have IU-like picture with vitreous floaters. So these things you need to differentiate. Thanks, Dr. Ramod Gupta again. We're talking about the questions, Rolika.
Yeah, I think Dr.
Yes, sir.
Rolika had taken up one question, and if
I'll
one of the
reframe my question. Yeah, so the question was that, like, if at all the collagen vascular profile is all negative and you have only ANA positive once and the repeat ANA is negative, and in such a case, patient kind of holds on to the ANA positive report, and as well as even the clinician, sometimes all of us feel that, okay, if there is one report positive, then we must look out for other possibilities as well. And clinically, the patient does have nodular scleritis. In that case, what do you do and how do you approach? I know Sudarshan sir has already given me his answer, but it would be good for everybody to understand.
Yeah, Somashila probably like the scleritis related. She has vast experience compared to any of us.
Thanks, Sudarshan. I'm sure everybody are experts here, Rolika. Don't let them fool you. They're just passing the buck. So if I understood the question correctly, I think that ANA positivity in scleritis, just an ANA positivity actually has no role. And all the investigations, so in scleritis, I'm sure the speaker must have also elaborated. All we're looking at is there a systemic known disease, that is RA or GPA or some other such serious disease, or are we dealing with infection? And barring that, the treatment is pretty much going to be the same. So to me, ANA positivity, I don't even perhaps even look at it.
Right. So
I think like
even
something you need to be more worried is if you have an ANCA, C anchor or something positive,
yeah,
then you need to be more worried about it.
That's
That is
right,
a
yeah.
little more specific. Yeah. Because even P anchor sometimes is not so specific, but like C anchor is definitely more specific, especially currently with the values being there now. Like you can quantify them. Like so that way it is really more specific compared to ANA or any of the other things.
right. And if only ANA is being done and it is positive, then it is ideal to make sure that the entire collagen vascular profile is done
Correct.
to be able to correlate the vascular profile with the positivity of ANA, because ANA is a non-specific marker.
Sometimes we may get
At
false
least
positive.
DNA one, not everything.
Yeah.
Sorry, sir.
Yeah,
I
Parma,
didn't
go
get
on.
you, sir.
Is ANA,
No, I
like
meant
you
like at
said,
least a double standard DNA, at least dsDNA,
Right,
if not
right.
everything else.
yeah, that is important to rule out SLE. So when you have ANA positive, we just not only the lab value alone, in addition to the ocular examination, we look at the patient as a systemic examination. Do we get any other systemic clue to suggest the patient has any underlying autoimmune disease? If it
Right.
is not, you get a ANA, then you get the ANA profile. If it comes negative, then we have to rule out. Sometimes what happens if the patient just recovered from a viral infection or following vaccination, the ANA could be false positive.
Right. You are absolutely true.
Yes.
Yeah. Thank you so much, everyone, for all your inputs and the speakers for great discussions. In fact, thank you for putting out things in a very systematic manner and a logical approach, and to clearing things out from anterior uveitis to intermediate uveitis. And it was really helpful for a lot of people, a lot of viewers, to understand how to put things in a proper manner. Thank you to the expert panelists for coming together and giving their views on the topics that have been discussed and their experience over the past so many years. Thank you, everyone. Thank you, Dr. Mahima, for co-moderating the session, and Sunil ji for helping us with the entire technicalities of the session. We will continue the UVR journey next week, and we will go on to the posterior segment. So looking forward to the next week's UVR session, and we'll all see you there. A very good night, everyone, and have a great, great Sunday night. So, thank you.
Thank you. Thank you,
Yes.
Thank you,
Rolika.
ma'am.
Thank you.
Thank you so much.
Thank you so much, Sheila ma'am, for
So much, ma'am.
joining.
Thank you, ma'am.
Thank you.
Thank you.
Bye, everyone. Thank you.
Bye
Thank you
bye.
so
Good night.
much.
Bye. Good night. Thank you and congratulations for excellent presentations to all the speakers.
Thank you, ma'am. We
Yeah.
always enjoy having you with us.
Thank you.
Thank you, ma'am.
Yeah. Thank you. Bye bye. Good night.
Good
See you next
night.
week.
Good
Yeah.
night,
See you
ma'am.
next week, ma'am.
Bye.